Systemic issues. Accused number 4 was late from Newco prison. We are told that there was an incident at the prison, and the warders had to assist with that incident before they could transport accused number 4. The state calls the next witness is Dr. Thabang Hlokwe. The witness name is not on the list. My Lord, this witness is going to testify in respect of exhibit VV in bracket 1. We have, the exhibit has already been handed up, but we hand up a complete copy that consists of 4 pages. Okay. We have marked them accordingly from page 1 to page 4. I've also given my colleagues a complete copy of the report.
Okay, thanks. You have the exhibits, all councils.
Yes, correct.
Okay, thanks. Okay. Yeah, can you say the witness in
English. Okay, your full name, please.
Full name is Thabang Hlokwe.
Thabang Hlokwe. Yes. Okay. Do you have any objection in taking the oath? Do you consider the oath to be binding and conscious?
Yes.
Do you then swear that the evidence that you're about to give will be the truth, the whole truth, and nothing else but the truth? If you say so, raise your right hand and say so help me God.
I swear, so help me God.
The witness is sworn in.
Thank you.
Doctor, what is your occupation?
My occupation in general, I'm a dentist. Usually the qualification, they call it the BDS. In full description of it is the Bachelor of Dental Surgery. I completed my qualification in SMU, which is called Sefako Makgatho for now, but before it was called Medunsa. So
udokotela osebenza amazinyo lokubizwa le ukuthi i-dentist ngakhokhela ke izifundo ze-BDS bayibiza ngokuthi ke i-Bachelor of Dental Surgery ukuthi ke usebenza ke ngamazinyo ngaphambilini ke manje bayibiza ngokuthi ke i-Dr. Sefako Makgatho kodwa ngaphambilini kwakuyi Medunsa.
And when did you obtain the degree Bachelor of Dental Surgery?
My completion was in 2019. I studied there for 5 years.
Ngagcina ke noma izifundo zami ngayiphothula ngayo u2019 ngafunda khona lapho ke iminyaka ewu5.
And doctor, what does your experience entail?
In general, what we usually do, we are taught from the beginning to be able to, one of the general function is to be able to examine a person from the waist up, and also looking at, most importantly, our factor and most important thing that we focus on, it's the head and the oral cavity.
Thina ke sakufundiswa ke ukuthi ke umuntu ke masimbheka ke simqale ke lana ke ezathi ukukhuphuka naye ke sigcila ke futhi ke kwikhanda ke kanye futhi ke na kuona ke ngaphakathi emlonyeni kumazinyo.
Now, doctor, if you say you examine a person from the waist up, can you be more specific?
Being more specific, we look at the general appraisal. If the patient from the waist up, we're looking at if there is the patient shows any sort of disabilities, any sort of defect, if the patient maybe it's been hurt from the inspection point of view, not proper examination from the eye view. We fully inspect the face, whereby we would put on gloves and then look at certain factors on the face, would look at if there is any lacerations that has to do with the nose, the mouth, the oral cavity, and also the neck.
Sikwenzayo ke ukuthi ke sibheke nje sibukeke ayi ukuthi ke umuntu siyamxilonga kodwa ke sibheka lokho esikwazi ukuthi singakubona ukusuka la ngaphezulu ke ukukhuphuka ke ebusweni sifaka ama glove ethu simbhekeke umuntu ebusweni ukuthi unayo yini imihuzuko anayo.
And then if we check the whole body from the waist up and we see anything that it's not within our scope, we are taught and instructed to refer these patients to certain disciplines so they can deal with those factors.
Uma siqeqeshwa ke noma sifundiswa ke ukuthi uma umuntu simbuka simbheka ke sibe sesiyabona ukuthi khona ke la engahambi kahle noma khona ukulimala ekhona masiqeqeshwa-ke noma sifundiswa-ke ukuthi thina-ke bese kufanele manje simdluliseleke mhlampe asithi-ke kudokotela ofanele okuyena-ke ozombheka.
And which disciplines would that be?
The disciplines mostly if there is severe injuries to the face, maybe we have jaw broken, maybe the patient appears to have some step defect, the face doesn't look properly the way which it looks like it's a bit deformed, we send it to a maxillofacial. If it's on the, has to do with the torso and the hands, and we see maybe there's something really wrong, we refer to a medical officer, in layman's term a general practitioner, which is a doctor, and then they take over from there.
Kuya ngokuthi ke ikuphi la esibona khona ke ukuthi ke akuhambi kahle uba ubuso kula emzimbeni ke ilana ke sibona ukuthi ayikhalana ke akukho ngendlela bekufanele ukuthi kungayo bese siyamdlulisela ke kudokotela ke osebenza ngako kona lokho.
Can you put your work experience on record?
I did my ComServe from 2020 until 2021 January in Tlhabane, a community health center district. That was my ComServe. And then from 2021 and onwards until present, I have been in private practice, which entitles that I have my own establishments that I run, and then I still work there and practice as a dentist.
Ukusuka noma ke umsebenzi wami ke ngo2021 sorry ngo2020 kuyoshaya ke u2021 kusebenzile ke eTlhabane la engenze khona ke abakubiza ngokuthi ke iComServe. Ukusuka ngaye ke u2021 kuze kube manje ke ngiyisebenzela ke mina ke kodwa ke ngiyisebenzela nginjalo kodwa ke nginesikhathi ke la engihamba ngiyosebenza khona ngale futhi.
Dr. No, ComServe might be common parlance in the medical fraternity, but in layman's terms, what is ComServe?
In layman terms, we, in our medical study area, we study within, after 2 years, we're already starting to do our clinicals. We see patients, real patients in normal settings, where we see them under supervisions of our superiors, and then after completing those years, after the 5 years, we have to serve the state every.
Okay. Okwenzekayo ke noma uma ngichaza ke lokho ukuthi ke nkathi sisafunda ke kuminyaka emibili ke ila esinikezwa khona ke ithuba lokuthi ke manje siyeke noma siwaboneke ama patients kodwa asizenzeli ke lokho bakhona ke abangaphezulu ukuthini noma abasiphethe ekuyibona ke ababheka ke noma mabuka umsebenzi wethu esiwenzayo ke bese kuthi manje ke uma sesiphela ke noma ke iminyaka emihlanu lena sesiyiqedile after 5 years.
So in brief, ComServe is community service.
Yes.
ComServe lona ke ukuthi ke siyosebenza emphakathini noma senza umsebenzi khona ke emphakathini.
And if you say you've got your own establishment, you refer to the fact that you are in private practice.
Yes.
Ukuthi ke mangikhuluma ke ngokuthi ke manje ne practice eyami ukuthi ke ngiyisebenzela ngiyimele.
I just want to show you a document which has been marked exhibit VV in brackets 1. Do you recognize that document?
Yes, I do recognize it. It's a form that we use in the Northwest District for examining any patient that we see in the dental department. It's the standard form that we use as dentists. We go through it with the patient, we have questionnaires, and then we have our own examination of the patient.
Lana ke le paper ke noma ke le document ephambi kwami ke iyona ke esisebenzisayo eNorthwest uma ke sihlangana ke noma sibheke ke i-patient la khona ke thina sibukela noma sibhekela lokho esikubonayo kanye futhi sixoxisana sikhulumisana nayo i-patient.
If I can ask you to turn to page 3 of exhibit VV in brackets 1.
Yes.
There's a place that is reserved for a signature, and there's a signature there. Whose signature is that?
That's my signature.
Kule page isithathu ke ongibuza ngayo la ongibuza khona ukuthi ubani wasayinda lapha yana yimina wasayinda.
Thank you. If I can ask you to go back to page 1. Can I ask you, doctor, to read the contents of exhibit VV in brackets 1 in the report, and if you can do so slowly, giving the interpreter a chance to interpret and explaining all the medical terminology.
So from the top of the page that we have, it starts with the stamp for the Health Department of Northwest Province, Republic of South Africa. So it then states that it's Tlhabane CHC, which is Tlhabane Central Health Community Center. So it says dental services. So the form starts off by patient's name, as we were saying, it's Bongani Sandiso Tangi, and then it has the patient's age, and then we also indicate the patient's gender, that it's a male. The patient's age, it's 29 years old at the time of the examination. So we also go on to allow the patient to give us the next of kin information, which is in this one, the patient stated it's Uleborile Petani, which was a partner, and then they also gave us the cell phone numbers, and there's also an address, which says it's 3125 Freedom Park, phase 2, and then the patient's age, which in this it was indicated that the patient was born in 1990 in December the 2nd.
Lana ke le form lena ke uma siqala phezulu ke yila inestamp khona ke somnyango ke wezempilo wase Northwest iyachaza ke futhi Tlhabane CHC ukuthi ke kusemtholampilo wase Tlhabane futhi ke noma ke kohlangothi elisebenza ngamazinyo futhi ke ichaza ke igama lapha yana le patient Bongani Sandiso Ndangi noma ke ngendlela ebhale ngala umtanzi umtanzi eminyaka yakhe u29 ukuthi umuntu wesilisa ukuthi ke lowo ke ahlobene naye ke uLebuheng Phethang oyipartner yakhe inamba yakhe nokuthi uhlala kuphi u3125 Freedom Park kanye futhi nokuthi ke ulimi lasekhaya isiZulu.
Yes, home language.
And then from there on, we also ask the patient's occupation, whether the patient is employed or whatsoever. In this case, when we got into contact with the patient was currently a prisoner, because we need to state whether it's a prisoner, it's a pensioner, or it's an unemployed law-abiding citizen, those things, and then we state that. And then from there, we get to the main complaint, the main reason why the patient is within our facilities.
Yeah, just a minute, doctor, sorry.
No, you can finish.
Yes, okay. Yeah, doctor, if I might interrupt you, you mentioned that he was a prisoner. Do you perhaps have an independent recollection of this patient?
Given the location where the Tlhabane district is, it was rare for us to encounter prisoners. So in my time working there, I would say for that whole year, he was the only person that's a prisoner that I saw that year.
Lana ke bese yaqhubeka ke nokuthi chazeke ukuthi ke mhlambe umuntu lona ngoba sifanele sibhale ke sisho ukuthi usebenza kuphi noma ke uhola impesheni lana ke kubhaliwe ukuthi isiboshwa usiyabuza kumshushisi ukuthi into oyikhumbulelayo leyo ukuthi ke wayisiboshwa kwindawo ke esikuyona noma sebenzela kuyona eTlhabane kwangavamisileke ukuthi sitholeke iziboshwa kulo yanyaka ke engangisebenza lapha yana kwakuyisona uyena kuphela oyisiboshwa noma isiboshwa sokuqala engahlangana naso kulo yanyaka.
And doctor, do you remember whether he came on his own, whether he was escorted?
My recollection, the patient was escorted. I remember seeing, I can't remember the number of the wardeners, but I remember there was a police cop and also a prison warden. And I remember there were some handcuffs on the patients when they came in.
Engikhumbulayo ke ukuthi wayengayihambeli yedwa ke wayiphelekezelwa ke lakhona iphoyisa kanye futhi ke nasojele nabo bekhona ke futhi ke efakwe nozankosi.
And if you can explain, doctor, as to where the examination took place and where the people were who escorted him?
Usually in any case and scenario, when we take an examination in a dental room, if it's a minor, we allow the parent to get in with the patient. If it's a partner, we ask the patient if they feel comfortable to having their partner within the examination room. But the only time that we only have with the patient, it's supposed to be me, the operator, and also my assistant, and also the admin people for the files. But the moment we start seeing the patient, it's only going to be me and the assistant, and then we assess the patient. And in this case in point, we were given space, I would say, because the wardeners and the policemen, They went outside, they kept the door a little bit open. They told us, or if we have any issues that we're having, we should quickly run to the door, because in any protocol, a state prisoner is not supposed to be left alone with an outside citizen without guard.
Okwenzekayo ke lana ngoba umbuzo ubuthi ke lana ke ngathi ke noma kwakuphi la owawu umbhekela khona ke futhi ke laba ababemphelelekezele babe khona yini ngokwenjalo ke uma kuukuthi ke umuntu osemncane ke ngomunye iminyaka noma ingane kuye kuvunyelweke ukuthi ke umzali abe khona ngaphakathi noma ukuthi umuntu futhi uhamba naloyo ke noma ke unkosikazi noma umyeni wakhe ke acabuzweke yena ukuthi uyafuna yini noma uyamvumela yini ukuthi abe khona ke kodwa ke lana kuba yimina naloyo ongilekelelayo kodwa ke la kuleli yona ke okwenzeka ukuthi laba ababempelekezele amaphoyisa nawusejele baphuma baya ngaphandle kodwa isicapha lesi ke bazivula kancane base bengitshela ke ukuthi uma kuukuthi khona ke inkinga ekhona kuzofanele ngibalekele kusona ke isicapha ngoba ke akuvumelekile ke uma kuukuthi umuntu uyisiboshwa noma ungaphansi kombuso ashiwe eyedwa engabhekiwe.
Yes, we may continue, Doctor. Main complaint?
So main complaint, usually when a patient arrives, we ask them why are they there, what's the main reason why they are there. So in this situation, the police corp is the one that indicated that the patient came for an oral examination. They want us to examine the patient per se according to our standard, the way in which we examine patient.
Lana ke masesitshelwa ke ukuthi kwakungani ke ukuthi ke lapho ke ubuliso leyo ngatshelwa ke iphoyisa ke ukuthi ke we-patient leyo ke yayinesifiso noma ifuna ke ukuthi ke ibhekwe noma ke ihlolwe ke la emlonyeni.
So I continued further. I remember continued further asking the policeman, or is there anything specific that I'm supposed to look out for so that I can rule it off or indicated in the situation. I remember the policeman spoke about if I should check if the patient had any sort of gold tooth inside their mouth. So that's where I basically started, but I treated the exam as standard, and then that's when I started with checking the dental history of the patient. Usually ask the patient if they've had any dental work done, whether they removed a tooth, whether they have a false tooth inside. The patient did state that they only removed teeth down the years. They pointed out the spots, and then from our knowledge, I was able to indicate which type of tooth that were removed there. So in that case, there were 3 teeth that were removed, and 2 were in the 3rd quadrant, and the other one.
Yeah, just a minute. Just
Lana okwenzeka ke ukuthi ke iphoyisa ke lasichazela ke noma ngabuza ke mina ukuthi yini kahle kahle lena ekufanele ngiyenze noma ekufanele ukuthi ngiyibhekeke washo ke ukuthi ke kukhona ke izinyo kwafanele ukuthi likhishwe kwakuyizinyo ke legolide ngase ngikhuluma naye ke futhi ngibuza ukuthi ngaphambilini usuke wawakhipha yini amazinyo ushilo ukuthi akhona ke amazinyo amathathu aseke wawakhipha yila nginako khona ke ukuthi ngisho ke ukuthi yipi inhlobo yamazinyo eseke yakhishwa ngaphambilini.
Doctor, can you explain the term quadrant?
Quadrant, we're speaking to the sides in which the teeth are located. In general, the way in which we chart and then we label the teeth. We label them in numbers, but the numbers take part in 4 quadrants. We have the first quadrant, which we call the first quadrant, whereby we start by every tooth it's labeled as its number. The quadrant is divided. We start from the middle of the head. We divide it into 2, and then we divide the jaw, the lower, the mandibular jaw, and the upper jaw. So we divide it to 4 segments. So we do it in a C format from the point of view of an individual. So we'd say we start on the first quadrant. It's supposed to be, the first quadrant would be on the right. We go on the left as we go down to the 3rd, and then we go to the 4th quadrant.
lana ke ila amazinyo ke ahlukaniswa khona ke uma sewabizwa ke ngama quadrant ke oqala eyesibili eyesithathu noma eyesine uzothi ke eyoqala ke uhlangothi langokwesokudla bese siya ke ngokwesokunxele siyehla ke siyenzansi bese siya ke kulo isithi ke uhlangothi lwesine ke noma ke fourth quadrant yona ke ezophinda izobe ngesezansi uhlangothi la ngakwesokudla indlela leyo esihamba ngayo noma esenza ngayo uma sesibheka ke amazinyo lawo.
You explained that there was extraction in the third quadrant. Yes. Can you mention the numbers?
The extractions that were done in the third quadrant, it was the 3-7 and the 3-5, and then we also have extractions on the fourth quadrant, which was the 4-4.
Okay. Can you explain the 3-7 and the 3-5?
The 3-7 and the 3-5, it's the teeth that are in the fourth quadrant, meaning it's the teeth that are sitting at the back partially, which we have at the back, we have the molars. So in different, what we're saying, the patient had an extraction of a molar and a premolar that was done on the third quadrant.
Lana ke esichaza noma esikushoyo ke ukuthi lamazinyo ke ayekhishiwe ke kwabo lamazinyo ke la uwathola engasemuva ke emlonyeni womuntu.
And then also on the fourth quadrant there was one which is a 4-4, which is also a premolar that was removed, which is on the fourth quadrant, which is on the right lower side.
Kunye kanye futhi ke nelilodwa ke kuhlangothi la ngakwesokudla la ngezansi elalikhishiwe.
Just in simple terms, you know, what is a molar and what is a premolar?
A molar, in layman terms, we have front teeth. The front teeth that we see when a person's smiling, we call them incisors. So incisors are the ones that when you enter food into your mouth, if you're going to chew something, you cut them with the front teeth. The ones at the back, we call them molars because usually in a way they mold the teeth. They have a larger surface area compared to the incisors. The premolars have a medium surface compared to it has a medium surface compared to the molars and also the incisors. So they are the middle teeth when we are starting from counting them from number 1 until the 8th tooth.
Which are the middle ones, the molars or the premolars?
The middle ones are the premolars.
Okay. Lana ke la athi akhishwa ke uthe uwa ewachaza ke athi ama molars la angasemuva ke wona bese kuthi kunalamazinyo ke ala ngaphambilini ke uma umuntu mhlambe ke esimala noma ehleka ke ekuwona owabonayo ilabathi mabe wabiza ke bona kodokotela amazinyo ama incisor bese kuthi kuba nala aphakathi nendawo uma bewachaza ke bachaza ngokuthi ke wona ke ama premolar.
Yes, may continue on the form, doctor.
So from the form, because that was the dental history we asked the patient, so I need to brief on how we label those depending on what we already have. So when we look at there, we go to the health questionnaire, whereby as a general healthcare professional, any healthcare professional, whether you are a physio, whether you are a audiologist, whether you are a dentist, whether you are just a normal doctor, even a nurse, when they examine a patient, they need to ask certain questions to find out by the disease status of the patient if it's going to implement in any sort of treatment that we're going to have.
Lana ke okwenzekayo kunemibuzo ke ekufanele ukuthi noma uyiphi inhlobo kadokotela noma usebenza ngani ke noma usumhlengikazi ke kunemibuzo ekufanele ukuthi uyibuzeke ngaphambilini kokuthi ungaqala usebenzeke ngayo i-patient.
It's correct. It's basically the history of the patient.
From the patient's point of view, them giving us their history from asking.
Mlando ke lo esithola kuyena ke lo muntu ozobona ke udokotela ngokuthi kube uyena ositshelayo ngaye.
Yes.
So the questionnaire goes, it's a number of diseases. So these diseases are the ones that are usually gathered through. They are the diseases that we usually use as a standard to check whether it's going to interfere in any sort of treatment due to the material that we're going to use. If there is any material that the patient has an allergy for, when we study initially, we check the allergies. So we check if the patient has any allergies. They state whether they have yes or no. If they have allergies, we need to state it out if there is there. In this case, the patient didn't have any allergies as stated by them.
Ngokuqala ke ukuya ngokuthi ke yini ke ezoyisebenzisa ke uma sesiqala ke ngomsebenzi ukuthi ke kulezo esizoyisebenzisa khona yini ezingamphathi kahle noma la athola khona ke ama allergy ila esithi siqale ngakhona ke noma umbuzo oqala khona ke nangokusho kwakhe ukuthi You said, did you answer? Oh, impendulo kwaba ucha ayikho.
Yes.
And then we go on to the heart. If they have any heart disease, then we want to find out whether the patient has any heart, which means or any chronic disease that's related to the cardiovascular, which is, it's written here, it says heart disease. So in this case, the patient said yes. And then we went further on to ask what do they mean when they say they have a heart disease. They spoke that back in 2014, they had a mining accident whereby they told them or they have some minor heart disease that they stated to us. And the patient couldn't elaborate further on that, and they say they're not taking any medication for that. So we just noted it down because it's something that we need to take into consideration if we're going to treat the patient.
Lana ngokumayelana ke noma ke okulandelayo ke awasitshela kona ke uma ebuzwa ke ukuthi khona yini ke akumhluphayo ke ngenhliziyo wabe sephendula ke ethi yebo ngase ngifuna ukwazi ke ukuthi usho ukuthini uma esho kanjalo washo ke ukuthi ngo2014 khona ke nje ingozi nje encane ke eyenzeka ke ngokumayelana nayo ke inhliziyo nokusho ke futhi ukuthi ke ayikho imithi ke nama medication ayithathayo futhi ke akazange futhi afune ukuthi ajuleke bese yachaza ukuthi yini noma kwenzekani kahle kahle.
So we also ask if the patient has any venereal disease, which is just involve the outside appearance of how they their veins and their vascular system kind of works. So the patient said, from their knowledge, it's no. And also we also went on to ask the patient about their HIV status, if they know whether they are positive or they are not. The patient said they are not aware of that. So they didn't want to conclude it, so we read it as no.
Okay. Apologies, Madam. Can you just repeat this one? The venereal?
The venereal disease, we're checking the vascular system. If they have any problems with the vascular system, meaning if they have any disease that involve the veins, maybe they have vascular thrombosis of the legs or one of those things that they have clotting factors and problems.
Lana ke uma bese ngimbuza ke kuloko okubhaliwe ukuthi venereal yona ke iphathelene indlela ke yokuhamba noma yokusebenza ke kwegazi noma ukuthi ke mhlambe ikhona ke lana einyaweni umuntu anenkinga nako wasephendula ke ethi cha buzile futhi ke mayela nesimo sakhe ke ngokumayelana ke noma ngokuphathelene ke nayo ke ingculaza iHIV wabe etho ke ethi yena ke cha akazi noma akanaso ke isiqiniseko salokho ingakho ke ngibhalile lana ngabhala no.
And what, doctor, what would the thrombosis of the leg be?
Most cases it's just systematic diseases, meaning or it's a disease that maybe an individual has due to inheritance or due to which is they are close together. In the exam, the heart and the venereal disease are close together because if you have a heart problem, it might lead to varicose veins, which means there's blockage in the veins and whatsoever. Those are systematic diseases that any individual can have due to heredity or maybe due to certain factors like maybe being overweight and those things that they're systematic.
Lana ke engikhuluma ngako mase ngikhuluma ke mhlambe ke ngokugula ke mhlambe ngokuphathwa inyawo ke khuluma mhlambe asithi nje igazi ke alihambi kahle ke nokuthi mhlambe ke ugula lokho owakuthola ke komunye womndeni ugula nje okudluliselwe omunye womndeni ngikhuluma nje ngento ezifana nalezo.
Yes.
And then when we continue, we ask if they have any lung diseases. Usually for lung disease, we just check if the patient knows if they have any problems with their lungs, whether they can't breathe well, or maybe they know they have TB or any other disease, which TB is tuberculosis. So the patients say they don't have that. They say they don't have that and they don't know any knowledge of having that.
Bese kuthi futhi ke ukugula ke okuphathelene nazo ke iphunga nokuthi ke mhlawumbe umbuzeke ukuthi mhlawumbe uyazi ukuthi unayo yini iTB lokubuza ukuthi ituberculosis abesithi cha ke nokuthi futhi ke akanalo nje ulwazi lokuthi ke lwakho khona lokho.
So, and also we went on to check if also another thing that you check if they have any problems with the bleeding because it affects the treatment. If the patient bleeds too much or they have a bleeding disorder, which in most cases it's we look for like hemophilia, which is the inability of the body red blood cells to clot and creating a clot to stop bleeding. So we checked with that. The patient says well, they don't remember having any of bleeding problems in regards to that. And we asked if they are on any medication, and as they stated, they said they were not on any medication. And then we went to their smoking as well. They said they don't smoke.
Lana ke mase kuphathelene nesimo ke mayelana ke negazi ke nokuthi mhlawumbe khona nje inkinga nayo nokuthi ke uphuma igazi kakhulu ke ngoba nalokho ke kuzoba nomthelela onako ke kumsebenzi esizowenza wabesesho ke ukuthi ke cha akanakho lokho. And then yila esesindlulele khona ke ekunokuthi sekumbuzeni ke ukuthi mhlambe ingabe uyabhema yini.
And then we went on further on to ask about rheumatic fever. Rheumatic fever, it's a heart problem which leads into infections of the heart valves, which leads to the body not functioning well. And the patient said the only heart problem they say they remember is the minor heart condition they had, and there was never stated to them what was actually the actual condition. So in this case we said no, and then we went on to check the cosmetic disturbance, to check whether the patient is in full mindset, whether the patient looks a bit disabled mentally. Those ones we usually ask the patient if they have ever been in a psychiatric hospital, those instances, if they do have ever been admitted to any psych hospital for not being in the right state of mind due to depression or any of that. The patient said no.
Lana ke uma sesiphuma ngayo ke rheumatic fever ke ukubheka ke isimo sezomzimba ukuthi ke indlela umuntu azizwa ngayo nokuthi khona yini ke ngaphathi kahle lapho abesephendula ke ethi cha kubhekwa nasibheka futhi ke nesimo ke somqondo ke ukuthi mhlambe akukho yini ukuphazamiseka okukhona ukuthi mhlambe umuntu lona wayeke waya yini kwisibhedlela ekubhekwa khona ke abantu ukuthi ke mhlambe akukho yini ukuphazamiseka noma ke ukugula ngengqondo anako nalapho impendulo yathi cha.
And then generally we ask, it's here in the questionnaire whether the patient is pregnant or not. Because it's a man, obviously we take no. A man can be pregnant. And then we also have the viral infections. In regards to the viral infection, we look for other viral diseases. We're talking about herpes simplex, which is in normal terms, things like chicken pox and other the viral diseases, a range of them. So we explained to the patient what kind of viral diseases there are. So the patient said they don't have any viral disease that they could remember of.
Olandelayo ke ukubuka ke isimo sakhe ke ukuthi ke uyithwele yini ke ngeke ke umuntu wesilisa ayithwaleke ila esesibhala khona ke sithi cha bese kubuzwa ke olandelayo ke ama infections ke la chaza khona okufana noma chicken pox wabe esephendula ke cha akanako lokho.
And then we all went on to check, ask the patient if they have any epilepsy. Epilepsy, most people in common terms, it's fits, where the patient tend to get into fits randomly due to triggers, maybe flashing lights and other things. So the patient said they don't remember having any sort of fits. So, and then we also went to ask if they have diabetes, which is in common layman's terms, it's called, they call it sugar diabetes. So which is they have any problems with the glucose level. In regards to that, the patient, they said no. And then we also have if they have any kidney problems, and then we explained to the patient what kidney problems is. The patient said they don't remember having that. And also with high blood as well, and the patient said they don't have any high blood and they are not taking any high blood medication.
Bese kulandelayo ke ukubheka ke manje ke lokubizwa ngokuthi ke amafiti ke ukuthi unawo yini waphendula ke ethi cha ushukela noma isifo sikashukela ugula ngoshukela phendula wathi cha inkinga yini ngeinto zakhe noma ke ama kidney akhe nalapho phendula wathi cha high blood washo ke ukuthi nayo ke akanayo.
And then we go on to ask if the patient has ulcers. Ulcers, it's normally common in people. They would say in common terms it could be a stomach ulcer, it could be the ulcer that's there on the trachea system, or the ulcers could be inside the mouth, which could be triggered by certain factors. Some people will complain maybe tomato, some would say maybe when they eat spicy things and whatsoever. So we checked in regards to that because it also impacts the type of medication we're supposed to prescribe for the patient if they have any sort of pain or infection. So we checked that and the patient said they don't remember having any sort of that.
Base sidlulela ke kuma ulcer ila lokho khona ke kwenziwa ke kuya ngokuthi omunye ke uzothi uma ngidle utamatisi ke omunye athi uma ngidle ukudla okushisayo ke siyabheka ke naloko noma ngoba kufanele sazi ke ukuthi ke yini ke medication ekuzofanele umuntu simnikeze yona ke waphendula ke wathi cha akada inkinga yalokho.
And then we also further investigate if the patient has any other disease. The patient will have to state to us if they do have, and if they say they are, the patient in this case that we didn't mark no because the patient said they are not sure if they have any other disease. So they were not certain about that, we didn't mark no, and also we checked if the patient has ever undergone any sort of operation. Could be leg, could be head, could be stomach, any sort of operation. The patient also stated no. And then we asked them if they're taking any recreational drugs. We're talking about alcohol, could be cocaine, could be heroin, any sort of drug or even yawa, but the patient said they don't.
Lana ke okulandelayo ke bese simbuza ke umbheka ukuthi ke mhlambe khona yini ama operations eseke wanawo ke washo ke wathi cha ke mhlambi ke idakamizwa icocaine noma yini ke naloko wachaza ke wathi cha.
And then we went on to check if one of the random checks that we do, it's when last was the patient been to a hospital, because it's quite very important. In most cases, when patients come in, they tell you, I've been to the hospital 4 or 5 times, and we ask them, what's the issue in the past 5 years? What's the issue? They say they don't know. So we need to check whether they've been to the hospital, so that if the patient has been to the hospital and they're really not sure of what's really happening with their state or their disease or whatever they have, we shouldn't proceed with certain things without making that sure. So we ask if they've been to any, they've been hospitalized in the past 5 years. They said they've never been. Specialists, they say they have never been there.
Buzeke nokuthi ke kule minyaka ke emihlanu endluleke suke waya yini esibhedlela ke la ukuthi mhlambe khona ke ulaliswe khona ke ngoba sifanele sazi uma kuukuthi ke ngempela kunjalo ukuthi ke yini ke ekuhluphayo ngoba sikwazi ukuthi singaqhubeka ke senze umsebenzi singazi ukuthi umuntu uhlutshwa yini ushilo ukuthi cha buzile ukuthi usuke waya wabonana yini ne specialist kuminyaka emihlanu endlule nalapho aphendula khona athi cha.
And then there is a medic alert member. Medic alert members are individuals that are within a community whereby they need to have either a net lace or a brace to show that they have any sort of condition that needs to be paid attention to. It could be whether the patient is medically retarded or the patient tends to be schizophrenic, in order for us to be able to identify that if the patient maybe gets into their medic nature and we don't know what's happened with the patient. So we ask them if they have any sort of those markings, so we're supposed to know about them. And they said no. And we also checked if the patient has asthma as well, and the patient said no.
Okulandelayo ke ukubuza ke nokwazi ke ukuthi lokhu ke ngendlela ebhalwe ngayo lana ke i-medic alert member ilana ke nabantu ke ozothola ke ukuthi ke kumphakathi loyo kunabantu mhlambe omunye ke une brace anayo ke noma efakiwe ke la esandleni omunye ke une necklace ayifakile echaza yakho noma eshoyo ke ukuthi lo muntu loyo ke kukhona okuthize okumhluphayo shiloko wathi cha sambuza ke ngesifubala noma ke i-asthma nalapho washo wathi cha akanayo.
And then already with the further details, it's the details that we actually, when a patient says yes to any form of information that we ask on the questionnaire, we state it down. I've already stated what the patient said, yes, they have had a heart problem, and then they already stated or they have reported to be admitted of a heart condition in 2014 following a mining accident, which was kind of really minor. Then we go to the vitals as well.
Bese kuthi ke manje ke eminye ke imininingwane ke bese ngishilo ke ngaphezulu ke ukuthi ke washo ukuthi kwanele inkinga ke yenhliziyo ke eyenzeka ke mining kodwa ke kwakuyinto etholakala ukuthi ke incane.
And what are vital signs?
Vital signs, usually we check the general stuff. In this case, because of us, we look at specific general notion, which is we check the blood pressure of the patient and also the pulse, which is checked by the medical people who screen the people, just to find out how the blood pressure of the patient is and also the pulse. In layman terms, the blood pressure is an indication of how the blood system of a vascular system of a patient is working, which is the blood system. If the high blood pressure, it's high, and roughly in most cases we say it's high if it's over 120, it's over it's 100 over 120, we say the blood pressure is within the highest region of the patient. So in this patient terms, we checked the blood pressure was within the rates of the expected range of it being high. So it says the blood pressure was normal for an individual. When we're saying high, what can strike the blood pressure to go high, it could be in an instant whereby the patient has been maybe immediately been in a physical activity whereby maybe they were running. Also another one could be a patient if maybe they were involved in a fight. The heart on its own will raise the blood pressure to supply certain parts of the body with a significant amount of blood. So the blood pressure will be high. It's one of the normal cases that any individual will have. The other indication of a high blood pressure is when the cardiovascular is within stress, which leads to, sometimes we have patients that we say they have high blood pressure which is uncontrollable, which in most cases can be led to systematic activities. Let's say maybe the patient is maybe overweight, or maybe they just actually in general their cardiovascular system is suppressed for somehow it's not functioning well. That's where we say the patient has a high blood pressure, and they will put them on treatment to regulate that high blood pressure. So in state of traumas, if the patient, yes, maybe they get into an altercation with someone, they are fighting, the blood pressure immediately, within, we say maybe within an hour, it might be high. But if it's that case, it's supposed to turn down and go down within a couple of hours or so, depending on how severe the trauma was. If the trauma was severe, it will probably strike up, go high, and then drop significantly. When it drops significantly, it automatically means that the patient has, it's either it's even in one of these, the body is in distress and the body is losing a lot of blood, meaning that the pressure towards the body system, the blood level, it's reducing, and the supply to certain parts is going down.
Uma sasibheka ke ukushaya ke noma ke i-blood pressure ke kunomlinganiselo ke okhona ke la esingathi ke phakathi kwakhe usithi ke liphakeme kakhulu uma liphakathi kwa100 kanye naye ke u120, kodwa lana sathi ke uma sibhala sasho ke ukuthi ke lingaphansi noma ke lila ekufanele ukuthi libe khona ke, ngoba ke iningi ke izinto ke noma izathu engabangela ukuthi ke igazi ke noma ke i-blood pressure yomuntu ke ibe phezulu. Asithi ke mhlambe umuntu ebegijima, mhlambe umuntu ke bekukhona ke kungqubuzana okukhona ke noma ke ukulwa obekukhona ke okuthatha ke isikhathi, kungayihora kungamahora ukuthi likhuphuke bese liyaphinda futhi liyehla liza khona ke ezansi. Yiyona ke esitshelayo ke ukuthi ke i-pressure yomuntu imi kanjani, futhi ke yini ke yini engaba yimbangela yakho khona lokho.
Yes.
And then the patient,
so the bottom value, you talked about the top value, the 117 and the 78. What does it represent?
The 117 means it's within, we have systolic and diastolic, and then the 117, they go both together. We look at the systolic and the diastolic, and then when it comes to both of them, the one that says 117, if it's under 120, it's the one that mostly we are concerned with. It's at that 120 would say the patient has a regular and normal high blood pressure. If it's just above 120, it's when we start looking at, or maybe the patient might be maybe a bit stressed, that's why the blood pressure is up. But once it starts hitting the 30s upwards, we start getting concerned with the patient has high blood pressure, meaning what is the diagnosis of saying what they had a high blood pressure. As it goes further on into 150, the severity of it, whether it's in control, whether it's under, it's not in control.
Uma sesibheka ke lana kuyena ke u120 ila esesibhala khona ke sithi ke ila ekulindelekileke, kodwa mase likhuphula ke liya ko120 bese sibheka ukuthi mhlambe ke umuntu ke mhlambe une stress ke likhuphuka liye ko150 ke sithi ke manje umuntu ke unayo ke i-high blood pressure.
And that value 117, is it the systolic or the diastolic?
It's the systolic.
And the systolic is?
It's 117.
And it is, it means?
It means it's normal.
Okay. Uma ke ku117 ngoba lana ke kubhalwe u117 kusho ke ukuthi ke ileli ke elinormal lelo ke noma ke ekuyilona.
And that value at the bottom, the 78?
That one is the diastolic. Also, we're just looking at if it's within the range above 90. If it's above 90, that's when we also have concern. But the most important one it's the one of 120 because it's the one that indicates or it's the one that we look after. If the diastolic is maybe slightly a bit high, if it's not, but the diastolic and the systemic it's normal, we kind of can rule it off as normal or within the range of saying, or we can say it's normal.
Lana ke kube kuno 117 /78 ke sinala khona ke siyambheka ke u78 uma kuukuthi ke u90 yakhuphuka ke uya ku90 ila esesiqala khona ke ukuthi manje sibe nako ke ukhathazeka kodwa ekuyiyona ke esibheka kakhulu ile eku120 nokukhuphuka ke iye phezulu sibheke ukuthi normal noma cha.
But in short, doctor, you said the blood pressure of 117/78 is within the normal range.
Yes.
Kodwa ke kafushana nje uma ke njengoba lana kubhalwe 117/78 ileyo ke leyo engathi ke ekuyiyona noma ke ejwayelekile.
This may continue. The next one.
And then there's also the pulse, which is goes hand in hand with the blood pressure. And then the pulse, we're just checking the rate. It could be, it's within. We check whether if how quickly the pulse is, how quickly the blood it's been pumped into the cardiovascular system. Usually, most people could see in movies. The person maybe has passed out and they're losing blood. They usually put a finger around the jugular area to check whether the pulse it's still there or not. So within this one, it's within the normal range. So if it drops, let's say considerably under 60, that's when we say the problem. The patient is really having. Maybe we say the cardiovascular system is failing, so the patient is losing a lot of blood, or the heart is giving up on pumping blood.
Bese kuthi ke la okubizwa ke ngokuthi yona ke ipulse uzobuka ke uma ubuka ke ama movie isikhathi esiningi ke uzothola abantu umuntu ebeka iminwe yabo khona lapha ubheka ke ukushaya ke noma futhi ke ukuhamba kwegazi ukuthi kwenzeka kanjani ke uma kungaphansi ke kwakhe u60 ila esesiqala khona ke manje ukuthi ke sibe kuyasikhathaza ke ukuthi ke ingabe isimo sithini.
Can you just put that pulse rate on record? What was the pulse rate?
The pulse rate was 72, so it's within the normal range.
Lana ke kwaku 72 ke esingathi ke iloko ke okuvumelekile nokwamukelekile.
Yes, may continue with the form.
And then from there the patient had a signature whereby they had a spot for a signature whereby they can sign to say whatever they've given us the above information is correct from their own side, and they did sign. And the date on which this was signed, it was June 22, 2020.
Khona nendawo ke la khona ke esisayinda khona ke lo ozobona ke udokotela lepatient ke ukusho ukuthi ke lokhu okala ngaphezulu ke noma lokhu asitshele kona kuyilona iqiniso ilanga ke okwenzeka ngalo lokho noma ke asayinda ngalo kwakuyi 22 zika June 2020.
The time is not reflected, Doctor. Can you more or less remember?
The time is stated in page 3.
Isikhathi sibhaliwe ke ku page 3.
Which says, if you can see due to the copy effect, it says it's 12:52 when the patient was seen.
Isikhathi ke patient yabona ngaso kwaku 12:52
when they entered to be examined, because this is the one that took place for when they were doing the vitals, which are the blood pressure and the pulse as well. That's when the time that they were seen.
Isikhathi leso ke abona ngaso kuma kwenziwa konke lokuyana ukubhekwa ke ukuthi ke isimo sakhe sikanjani.
So we proceed to page 2.
So in page 2, it's the clinical examination whereby we examine the patient from the extraoral perspective, meaning where it's where we start checking the patient generally speaking and getting into certain details. So in what we do, we are supposed to check in the extraoral examination. We check the general appraisal, which is what we look at the patient and we look at how whether the patient is abnormal or the patient looks to have any maybe sort of disabilities or any sort of defect that to a normal medical healthcare professional terms, given the anatomy that we learned and the conditions that we are given, do they look do the general appraisal look normal to a normal looking person? In this case, which is we said it's normal, meaning when we look at the patient has no particular abnormalities. Maybe there is, I would say, maybe an arm disability, or maybe the patient has some sort of maybe they're showing, or maybe they're wearing an anklet brace to show that maybe their leg is hurt or anything. The just patient look normal to not be any sort of disability. And then we check also the neck area if there is any sort of bruises. Those ones we check in general of saying, what if maybe if it's a patient, maybe it's a child. When we look at them, they have bruises around the necks and also the face. It means, or maybe it's an assault patient. Then that's when we refer to certain disciplines to be seen by a medical officer. Then they can take it further and see whether what's really happening from there. So with this patient, there were not really any sort of abnormalities when it comes to the patient being bruised, disabled. The patient really looked pretty much normal at the state of being examined.
Lana ke ukubheka ukuthi nje i-patient lena ikahle yini, akukho yini la ekubhekeka khona ke noma ebonakala khona ke ukuthi mhlambe umuntu lona ke okhubazekileke uma mhlambe asithi nje une necklace anayo noma ke enyaweni noma ebrace anayo khona lapha yana eshoyo noma echazayo ukuthi ke kukhona nje ongahambi kahle kuyena ke, kodwa ke kule noma mhlambe asithi umuntu lona obonakalisa ukuthi mhlambe ulimele la ekuzofanele khona ke andluliselwe ke udokotela ke okuzoba uyena ke osebenza ngalokho ozombheka, kodwa ke kulena ke i-patient kwabonakala nje ukuthi cha akukho okungekho akahle konke kwakukahle.
And then we went to check the TMJ. The TMJ, it's the joint. The joint whereby the jaw joins itself to the skull. It's in layman terms, we would say it's the skull. So we call it the cerebromandibular joint. It's sitting right adjacent to the end of the ear, right over here. So what we usually look for, it's in most trauma case patients that maybe they have been hit, or maybe the patients have been involved in a car accident. There will be maybe some deviation, clicking sounds when the patient opens the mouth, or maybe when the patient opens the mouth shifts to the left or shifts to the right. So we look for those things, or whether it's a systematic fact that the patient's TMJ ligaments are not strong enough, the joint just deviates from birth. So we check those things to just know, because since we're working in the mouth, we require the patients to open wide. If the patient has any defects, they open wide, it becomes dislocated. We need to know if it was our own doing or the patient came with those issues before. So that's what the cerebromandibular joints are assessed for.
Bese sibheka ke nokubizwa ngokuthi ke ama TMJ, wona ke ama joints ke uma ewachaza ke la kulohlangothi noma ke ngesenzansi nje kancane kwendlebe ke, lokho kungabangelwa ke mhlambe ukuthi umuntu wayeke wasengozini yemoto, mhlambe uma ngabe ekhuluma ke kunendlela ethize ke amazwi aphuma ngayo noma ke aclicka ngayo. Fanele futhi sibheke nokuthi ke uma lokho kukhona ke lokho ukuthi lokho kwenzeke nkathi ela kuthina noma indlela afike engayo leyo.
So and also
noma futhi uma ngabe ekhuluma uyabheka ukuthi mhlambe ngesinye isikhathi uma ekhuluma umlomo wakhe ushiftela ngaku left noma ngaku right.
Yebo. We checked that as well. And then also we went to the lymph nodes. Lymph nodes
Yes,
is
just before you proceed, doctor, what was the clinical finding regarding the TM joints?
they're normal. They look normal. The patient didn't look like they had any disabilities or anything that's off. That's why in the paper we ticked normal in regards to that.
Ilapho ke uma ubona lana kule form kuthikiwe ke unormal ukuthi ke ungokwenjwayelo noma ngokujwayelekile ke, ngoba ke masimbheka nimbuka ke ngimbona abonakala ukuthi akukho nje okungekho kahle noma ungekho ngendlela.
And the one that we also check, is one of the most important ones, is the lymph nodes. Lymph nodes is the lymphatic system. It has a number of functions. It's maintaining the fluids in the body. Usually what really happens is with the lymphatic system also maintaining fluids, meaning, or if there is any infective fluids that's within the body, maybe the patient has an infection or they had any fluid irregularities regarding that's threatening the immune system. It's the line of defense for the immune system. So if they're having those issues, practically when we check them, we palpate them to check whether if they are swelling or they are palpable or they are normal. So most of the time when they become swollen and they're a bit palpable, that's when we say maybe the patient has an infection. So in regards to us, we check the lymph nodes of the neck and the submandibular. Submandibular is just below the mandibular, there's a triangle between the neck and also the mandibular, which is the lower jaw. So we palpate there to check whether they are abnormal or they are normal.
Lana ke ukubheka ke ukuhamba nje kwama fluids ke emzimbeni futhi ke lokho kwenzeka ke kuhlangothi ke la lentamo ke nokubheka ke ukuthi futhi ku normal noma akukho normal yini noma kunokuvuvuka okutholakalayo khona lapho noma cha.
Doctor, just explain palpate.
Palpate, we wear gloves and then we go around the area where the lymph nodes are. We smoothly press on them to hear whether there is any sort of hard surface that's there. If it's hard, that means the patient could be having a systematic, the lymph node system, it's failing. In most cases, minimal rates, they usually like stating in cancer patients when they are actually really sick and then it's spreading quite quickly. You find that the lymph nodes are more swollen, but infections, they become a bit more tender, and then the swelling shows it's not really as severe. It's only when they have serious health issues whereby they become very much hard and swollen.
Lana ke uma senza lokho ke sithatha ke noma sigqoka ke ama gloves la kuthina ke ezandleni bese siwabeka ke khona la ukuzwa ke ukuthi khona yini okungekho kahle ke noma futhi ke isimo sangakhona sithinike lokho kuyenzeka ngenye inkathi ukuthi ukuvuvuka lokho ke kube kakhulu ke ikakhulukazi ke kuma patients ke ayo ke icancer kodwa ke lana ke uma kuphathelene nayo ke ama fluids lana ke wona ke athanda ukuthi kube khona ke indawo engathi iba lukhuni ke khona lapho ilokho ke esikuzwayo uma sesifaka wona sigqoka lawo ma gloves.
So in this case, the patient's lymph nodes, they didn't look abnormal. We take normal, they looked normal. We didn't find any irregularities when it comes to that.
Asizange ke sithole lutho ke kule patient ke esingathi ke kwakungahambi kahle noma kungekho kahle.
Now, doctor, except for infection, is there anything else that can make the lymph nodes to be hard or swollen?
Yeah, in states whereby in very specific states whereby if maybe the patient was involved maybe in an accident or maybe they were assaulted and maybe they get fractured and then maybe they are not medically attended to, it could lead to opportunistic infections that leads to the lymph nodes being swollen to indicate that there is an area in the body that's open, that bacteria is getting in or virus is getting in and it's infecting the body, that needs to be paid an attention. It's more of an indicator of whether the immune system it's functioning well or it's failing.
Lana ke lokho kuba yona kuba kona ke inkomba ke yokuthi ke mhlawumbe umzimba lona ke noma immune system ihamba kahle ke isebenza kahle noma cha iyafela ke lokho kungabangelwa ke into ezahlukile ke ukushaywa mhlawumbe umuntu ke ayisengozini ke yemoto futhi ke manje akwatholakala ke ukuthi ke athole ukunakekelwa noma ke ukulashwa ke kwalokho bese ke tholakala ke ukuthi kukhona ke lana ke mhlawumbe ke uma sekungena ke kube infection itholakala ngaleyo ndlela.
And then we went on to the palate. The palate is the roof of the mouth. Whenever anyone takes their tongue up.
Sorry, doctor, just at the intraoral exam.
Oh yes, it's sorry I'm walking past through. Sorry about that. The intraoral exam. When we come to the intraoral exam, it's the inside the mouth. That's where we start looking at what's happening inside the mouth. Mostly we check certain parts of the mouth. In their face, we have the lips and we have the buccal mucosa. So when we say the lips, we're referring to normal lips, the ones that we speak with. And when we're talking about the buccal mucosa, we talk about the space between the teeth and the cheeks. So in that fashion, when we look at the lips, we look at within the lips whether there is a fleshy red, which indicates that maybe the patient has some sort of trauma. The mucosa was hurt, or it has blood clots to show that maybe there is any sort of trauma that happened there. Because in general, it's supposed to appear pink in general. It's supposed to appear a relative color of pink. And most cases you find with the other patients, it's not pink due to hyperpigmentation. It's something that happens systematically. It's an abnormality, but not really of concern, because due to our melanin, the type of color that other people are, they will have more pinker gums, but there is a certain type of fleshy red, and also sign of blood clots within the mucosa that indicates that there could be any sort of trauma, or also if there is ulcerations to show, or maybe there is some cuts that happen there. Trauma could be caused by anything. It could be the fact that maybe the patient was hurt, they heated a chair, and then the lips bounced on the teeth, or if maybe, for example, maybe the patient has some ulcers that were caused by maybe something they ate, or maybe they have some disease, like maybe they have herpes, or the beginning of an oral cancer. So those will be the irregularities. But when we don't see those things, or fleshy red, or seeing any ulcers, or we see any sort of indicates of maybe there's a bit of blood clot within the mucosa, we rule it as normal. That's what we take here.
Lana ke uma sesibheka ke ngaphakathi ke emlonyeni womuntu ubheka ke ukuthi mhlawumbe khona yini ongathi mhlawumbe uthola ke kubomvuke ngaphakathi emlonyeni okungabangelwa ke izinto eziningi ke ukuthi mhlawumbe umuntu ushayisekile ke khona la anqubuzeke khona ke mhlawumbe asithi nje esitulweni ke kwase ukuthi ama lips akhe ke ashaya ngaphakathi ke ngoba ke ngokwenjwayelo ukuthi umuntu ufanele ubone ngaphakathi, uma ubheka ngaphakathi ke ubone ke umbala opink, kodwa akusiyena ke wonke umuntu la uzobona khona ke upink, ngoba abanye banezimo ke abakhule nazo, noma ke abazalwe noma abadalwe benazo ke kungenzeka kungatholi ke loyo pink loyo. Lokho ke okungabangela ke ukuthi ube uyabona ke manje loba bomvuko obungaphakathi, ibona ke mhlambi obungabangela ke ama ukuthi umuntu abe nama ulcer. Ikona ke esikubhekayo uma sesibheka ngaphakathi ukuthi nje konke kukahle kungendlela yini ngaphakathi emlonyeni womuntu.
And another thing that's also there that we check is the oral pharynxes and the tonsils, which they are situated at the back of the mouth. It's they're saying it's the end of where the oral cavity ends, and then it's where the trachea, in layman's terms we call it the throat, begins. So the reason why we check these two is they are also associated to sort of infections. If maybe a person says or they have tonsillitis, you find or their throat is swollen, is due to maybe a viral infection that could be in the system, especially in the oral cavity or in the upper respiratory system. So meaning also the oral pharynxes, maybe some of them, they could be maybe appears if they are blocked, clotted. Those ones we look at for. It happens with most of the patients that have an electric shock, whereby they're allergic to something, and then they might end up maybe needing adrenaline to relieve that electric shock. So we check for that. We allow the patient to open their mouth, and then we tell them to depress their tongue down, and then we use a mouth mirror that's almost as if it's a spoon, and then we look exploring at the back to check if whatever is inside the mouth or whatever is happening in the face, is it affecting the tonsils, because the tonsils also, they are part of the lymphatic system, because you could miss the lymph nodes that are on the submandibular and also on the neck, but the infection could be progressing itself at the back in a form of tonsillitis.
Bese sithi ke manje ke lana ke sengicela khona ke patient ukuthi ke avuleke umlomo ke futhi ke abese ecindezela ulimi lakhe ke ila esofaka khona ke isibukeke esingathi ke isipuni ke isona ke esikhombisayo ke noma ke esikwazi ukuthi sibone ngaso ngaphakathi ke ngasemuva ke emlonyeni, ila khona ke ama tonsils omuntu atholakala ngakhona ke, ila futhi ke ekuqala khona ke umqala ke, ngoba ke manje sesifuna ukubheka ke ngaphakathi ke ukuthi ila khona ama infections nawo athi atholakale khona.
Would any trauma to the oropharynx and tonsils affect the way that they look like?
In instances, maybe we would say the patient, there is a trauma to the neck, and maybe the trachea it's been bruised, or there is any sort of trauma to the neck. Most cases, sometimes, if it depends on the severity of it, how bad it is. it can progress itself with maybe the patient appears to be having a swollen trachea from the inside of the mouth. It could pronounce itself as that way. In severe cases, meaning what sometimes patients could have assaults, there could be heat, there could be done whatsoever, but since there was no any sort of hits or trauma to the neck or maybe to the face, that might not have any sort of disabilities on that one.
Asithi ke manje umuntu lana ushayiweke noma ke ushayiweke lokho ke futhi ke kuzoba nomthelela ke ngoba ke manje kufanele ke sesibheka ke ukuthi ke ukuvuvuka okungathi kube khona ke engakhulukazi ke emqaleni ke kodwa ke uma kuukuthi ke cha ke akukho kwenzekile akashayiweke lokho ke akukho ke nje ozokubona noma kuzotholakala.
So, and then we move to the palate. The palate is the roof of the mouth. Everyone who lifts up their tongue and then put it on the, I usually say in most cases to layman terms is maybe for patients who report to maybe they have irritation of the nostrils, they usually put their tongue on top of the roof of the mouth. So usually when we check in our field, we just check whether the palate is showing any sort of let's say ulcers, maybe there is any lesions that's there, maybe let me just say lesions coming from any sort of disease that's there, maybe the patient has nasopalatal cyst that's there. Those are the things that are more disease related. So in most cases when we check for that, we just check for the disease part of it. We don't look for any sort of trauma or we look for any sort of condition that's associated beside the diseasal part of the body when we check the palate. And also the size of it, whether it's deep enough, whether it's wide enough, those are the things that we check.
Akunye futhi ke bese kuthi ke ipalate ke ila ke ngaphezulu ke emlonyeni ke la umuntu acela khona ke ukuthi manje akakhuphula ke noma ke anyuseke ulimi lakhe ubheka ke ukuthi akhona yini ama disease atholakalayo ke ngaphakathi ke ama ulcer noma kuyini ezotholakala ngaphakathi ke la emlonyeni uma ukuthi umuntu ukhuphule ulimi lakhe walibeka la phezulu.
And then from there, we check the floor of the mouth. Usually we ask the patient to lift up their tongue into the roof of the mouth so we can check the floor of the mouth. Those are also disease related and also systematic, because when we check the oral cavity, we want to find out one of the things that we're more interested in is the thickness of the patient's saliva, the thinness of it. So underneath the floor, underneath the tongue, which is the floor of the mouth, it's where salivary ducts are. Salivary ducts are secretors of saliva. So we want to check whether it's blocked, it's clotted, or whether any of it is hurt, because that might affect the thickness of the saliva, in which the rate in which the patient secretes a lot of saliva or secretes low saliva, but because those also affect the patient's breath and whatsoever, but it's more of a systematic notion. It has nothing to do with any other thing except for the systematic notion. We would say maybe in cases of traumas, yes, we would check maybe if the patient has severe trauma, the jaw is broken, there's dislocation of the jaw, the floor of the mouth will be affected. And that's when maybe we'll also check if there was any nerve that was damaged that runs through the floor of the mouth, which is the lingual nerve. And those are the things that mostly is. But most of them we check for the systematical part, how it's going to affect how we're going to treat the patient for us.
Lana ke indlela ke ezositshela ke noma ezositshengisa ke ukuthi sizosebenza kanjani ke nayo ke ipatient lena ngokuthi ke simceleke ukuthi ke aphakamiseke ulwimi bese sibheka ke la phansi ke emlonyeni sizobheka ke ukuthi mhlambi khona yini ukubloke kokukhona ke kwawo ke amatheke kanye futhi noma ke khona ke mhlambe ukungahambi ke noma ukublokeka kwalo igazi. Ubheka nje indlela yokusebenza uma sithi ke akaphakamise ulimi sizobheka la phansi emlonyeni.
And also we check the tongue. The tongue, everyone knows, we all know the tongue, it's the one that's sitting in the middle of the mouth. So in terms of it, we're just trying to check if the tongue has any sort of radiant color. Maybe there is a certain pattern that we see that we don't understand. The pattern, we're only talking about lesions only, and then also the color, we're not really most concerned about it due to pigmentation. Some patients' tongues would have maybe browner spots, but if those are the things that we tend not to put much focus on because people differ in regards to that, but we're looking for any sort of lesions. If the tongue was cut, or the tongue is bruised, whether the tongue has any ulcers that's there. Ulcers could indicate that the patient may be having some sort of rare cancer, or they're just having some reaction to whatever they ate or something else. That's what we're checking. But in most trauma cases, if we have a trauma or we have a patient that's been assaulted and whatsoever, yes, we check it to just check if maybe it's swollen, because if it's swollen, we need to put a careful attention to it because it ends up blocking the mouth, the throat at the back, and then it affects the breathing of the patient. But besides that, we also check if there is the tongue, the size of the tongue. We have some patients who have larger tongues, meaning when they close their mouth, they put their tongue on the floor of the mouth, it gets depressions from the jaws. We just check for that because it also can affect certain function of the patient, meaning it could lead to the patients having some speech problems, which could be one of the factors, but those are one of the things we're saying. It's systematic. It's some follow-up of disabilities that we look for.
Uma sibheka ulimi ke iningi kakhulu ke izinto ayibaleke eyibhekwayo ke ukuvuvuka kwalo ke mhlambi ke kubangelwe ingozi ke ukushayeka noma ukushaywa, ukubheka mhlambi ukuthi ke kunokusikeka okukhona yini olimini. Ngenye inkathi uthola ke ukuthi abanye abantu ke siyazi ukuthi umbala olimi ngiyawazi ukuthi unjani, kodwa kuthola abanye ukuthi kunama spots ke abrown akhona, kodwa ke akusona izinto lezo esigxila kuzona, kodwa ke ukushayiseka ke okuzokutshela ukuthi mhlambe khona okwenzekile. Abanye abantu uzothola ukuthi ke nabo ke amalimi abo awalingani, abanye banamakhulu ukundlula awabanye.
Dr. C, the clinical funding is not indicated here.
Yes, usually in most cases it becomes quite very tricky to point out, especially when it comes to the tongue. When we can't find anything that's really abnormal, we don't really mark it as normal, because in most cases the tongues are not all the same. So it's enlisted here to check whether it's normal or it's abnormal, meaning most cases when we see no disability or abnormality, we just don't tick it because the normality of it's not standard. So in this case we didn't tick it because there is no absolute standard, like I stated. For example, with the lips and the mucosa saying most of them has to be pink. So with it, the colors vary, and we're just looking for the sizes, the ulceration. So if we find those, then we're going to tick abnormal and then write the Antony there. So write whatever we found that's abnormal. But here we don't tick because we're actually saying the patient's tongue is up to standard selection. So we don't really tick that because of that fact.
Lana ke kuyangabhala lutho ke eduze kwaloko elimi ke ngoba ke akukho ke ngoba sothi ke ulimi lakhe ke umuntu noma ipatient leyo ke ngathi ke kuloko ke okulindelekile, ngoba ke kona ke akufani nezinye la uzothi khona ke yilokhu nalokhu okulindelekile noma ke okufunayo kulona ke ulimi, ngoba ke sibheka nje ukulimala ngoba kube kunokulimala kunokusikeka okukhona ke ila bese uthika khona bese siyabhala ke eceleni.
So in other words, there were no abnormalities detected.
If there were abnormalities, we were going to tick abnormal and then write the abnormalities that we actually came across.
Uma ukuthi kukhona ke kwakukhona okwatholakala kulona ke ulimi sasothika ke bese kuyabhala ukuthi yini leyo etholakele.
Doctor, can you just place the clinical finding of the floor of the mouth?
The floor of the mouth clinical findings were the floor of the mouth was normal. It wasn't too deep, it wasn't too shallow, it was up to normal standard that we look for. There was no lacerations, there were no ulcers in that regards.
Uma sibheka ke la phansi ke emlonyeni akukho nje okwatholakala ukuthi ke mhlambe kunama ulcer, kukhona nje okungabukeki kungendlela ke yilakho ke kubhaliwe ke noma kwathikwa unormal.
Yes.
So we're going through to the gingival and the periodontal. These are the more invest stuff in the dental field, which is the gingival. It's part of the gum that we say it attaches to the tooth. It's in most cases it's the free part of the gum. When we examine the patient, we usually take some sort of probe in between the tooth and the gum, a very, very thin, I would say almost needle thin standard. We put inside, it has markings to check the length and whether it's too deep or whether it's it's reduced from normal standard compared to the other ones. And then the periodontrum, it's in layman terms we'd say it's the cushion. We call it the cushion. It's the ligament that's between the bone and the tooth. The cushion that we're talking about, let's put it straight, it's like it's the cement to brick laying. So in order for the tooth to be attached to the bone, there has to be a periodontrum there. So if that periodontrum has a disease, that means the teeth won't be stable. It will start moving upon maybe patient chewing, or even if the patient touches it like this, and then it will start moving, showing that there is no cushion in between to stabilize the tooth. That means it has a disease, it's been reduced, and it's been affected by bacteria, and there's some sort of infection inside there. So in regards to that, we check the level of it, and we check whether it have any sort of infections that's there. So with this patient, the only thing that we noticed, it was that there's gingival recession. Gingival recession, we're just talking about the fact that the gums, relative to other ones, they're showing that the gums are not attached to the cervical part, which is the end of a crown. A crown, the tooth, it's divided into two parts: the crown and the roots. So the cervical part of the tooth, it's where the tooth starts becoming a root. So if it's reduced below that part, we would say it has a recession, it's gone under. So that one, it's also a systematic part. It's caused by maybe long-standing plaque that resulted into bacteria end up eating away the gum, infecting it, resulting for it to eroding and then reducing. So when we check the patient, the other factor is if the patient has maybe a habit of using maybe a harder brush. We have patients who use a toothbrush for like maybe a year or two, and then the toothbrush, when it becomes hard, it ends up corroding, and the gum is a very thin and sensitive part of the tissue, to a point whereby even if you chew a bone, you make a mistake, it hits the gum, you can end up having the bleeding of the gum. So, but if you're constantly brushing on that free part that attaches there, you're corroding it, then it ends up being resected. So it's one of those things. In this case, we found out there were 3 teeth that had that, and it was the tooth on the 4th quadrant, the first one on the lower right side, and the second one on the lower right side as well, and then there was the first one on the lower left side that had that part of recession.
So what is doctor actually saying? What happens to this client here in this one? This patient, what is doctor saying?
In this case, it was abnormal, just due to the fact that maybe when we look at it, we do further investigation by asking the patient whether they, in this case, it looked like the maybe it was
the gum.
The gums
Okay.
were abnormal.
Lana ke esikutholile ukuthi kuningi lokushiwo amagam ale patient ayengekho normal.
And then from there, we go to Engel classification. Engel classification, it's our part for classifying the way in which the patient bites. You know, certain relativity of a certain tooth from the upper to the down, the way in which they come together to classify whether the patient has abnormal teeth or normal teeth according to a certain standard that was drew from a survey that was made at the beginning of dentistry to classify patient's identity via the grouping of the way in which the teeth are. So the patient is on the class 1, meaning what it's a standard classification of a normal occluding teeth of a patient.
Uma sekubhekwa ke noma kuhlake noma ke kuclassifywa ke amazinyo ke mhlambi ke indlela ke ongathi ke uhlafuna ngayo ke uma kubhekwa ngokwama class uzathi indlela ke lena ejwayelekile noma ekuyiyona ke elindelekile ngoba ke yona ke uma beclassify kube kutholakala ukuthi uclass 1.
Yes, and the only findings that were different from the patient's teeth relativities is the fact that they had spaces in between their tooth which sometimes some patients do have, sometimes patients don't, due to their jaw being bigger than their teeth. So the teeth tend to try and spread out and fill up the space. So also that one, it's a normal thing that comes with the patient. Patients are born with it. Some is due to maybe the patient removed teeth early and whatsoever. In this space, in this instance, the patient has interdental spaces, meaning or between the teeth that are in the first quadrant, the front one, there were spaces, but it's just whether some patients have it, don't have it due to certain factors that took place, whether they were young, or it's just the heredity thing. Because some families you find all of from the mother to the child, they have gaps, because that's how the family is.
Lana ke ukuthola nje ukuthi ke amazinyo lomuntu ahlangane yini, amanye uzothola ke ukuthi kunama space akhona ke, abanye benziwa ke ukuthi ke ufuzoko lelo ukuthi mhlambe ke indlela akhule engayo khona okwenzeka esemncane ke, kodwa uthola nje ukuthi nje cha kunama space akhona ke phakathi kwamazinyo, abanye banawo abanye abanawo.
Doctor, if I can just maybe briefly take you back to the previous clinical finding regarding the gingival recession on the fourth quadrant and the third quadrant. Is that in any way related to oral hygiene?
Yeah, it's related to oral hygiene. Could be poor oral hygiene or the patient's inability to have oral intelligence to know on how to brush their teeth, on how not to brush and when to change their toothbrush. So it's mostly related to we call it an oral hygiene standard, because oral hygiene is the instructions, it's when it comes to how patients knows how to clean their mouth, when to clean them, what to use. So it's oral hygiene related.
Lokho bekuchazwe ngaphambilini ke lokho okubizwa ngokuthi yona ke i-gingival kuhamba ngokuthi ke indlela ke umuntu ke anakekela ngayo amazinyo akhe, ukwazi ukuthi kufanele awaqhubhe nini ke nokuthi futhi kufanele ukuthi ke i-toothbrush futhi awaqhubhe kanjani nokuthi i-toothbrush ishintshwa ngasiphi isikhathi noma emuva kwesikhathi esingakanani.
Does trauma play any role there?
In most cases, no. Unless if maybe the only part it will play if maybe the patient had sort of tooth fractures that leaded into maybe the teeth wanting to be brought back in by aligned back, and maybe through the process of trying to align them back, maybe there could be a bit of gum cutting to try and balance the teeth, put in plates and whatsoever. Those we only see in patients that have been treated for trauma, not in an instant whereby the patient is kind of really traumatized.
Futhi ke nokulimala ke kuba nawo ke umthelela ke lapho ubona ukuthi mhlambe bekhona ke ukulimala obekukhona ke mhlambe amazinyo ke afuna ukubuyisela kwisimo sawo noma ngendlela ke ebekade engayo ngaphambilini noma ngaphambi kokuthi umuntu athole ukulimala.
But in this particular instance, the gingival recession, doctor said it was due to poor oral hygiene.
Poor oral hygiene, yes, which showed that the patient's oral hygiene wasn't really, it was fair. We would say it's fair, it wasn't really that much poor, but it was really fair because there were certain teeth that were really affected. We wouldn't really say when it comes to the oral hygiene, we would say it's poor, fair, and then we would say it's good. So with the patient, would say in terms of the rating of it was fair. Fair meaning what it could be poor. It could be good when we look at certain other parts of the teeth.
Uma ke lana uhlanganisa ke amazinyo ke ubheka ke indawo ezithize noma ke amazinyo athize ke kanye nokunakekela ke wona ke amazinyo noma umlomo ke lana singathi ke kwakumaphakathi nje nendawo ke ngoba ke ungathi ke uphuwa noma ugood noma ufair, lana ke maphakathi nendawo ngendlela ke anakekela noma ke xubha ngayo amazinyo.
Yes, you may continue on that.
Yes, and then from there we have this charting. It's a charting that I already explained at the beginning when I was talking about the teeth that were being extracted, that we have the first quadrant, we have the second quadrant, we have the third quadrant, and we have the fourth quadrant. In detail, it's the charting that we use to mark which tooth is rotten, which tooth is missing, and which tooth needs to be filled, which tooth is broken. So we have certain markings that we mark on the chart. If you look at the chart that we have here, we have the 1.5 and the 1.7 and also the 4-8, they have zeros on top of them, and also the 2-8 and also the 3-8, they have zeros on top of them. The zeros, it's an indication of the fact that if they are zeros and they are not shaded inside, they're just a normal zero, it shows that the patient has caries there, meaning or the tooth is rotten, it has some black spot that needs to be restored. But if it's shaded, it means or the patient has had fillings, and the fillings are inside the mouth. We're just marking points whereby the patient was saw a dentist and then fillings were done. So, and also if there is a dash that's cancelling a certain block, it shows us those teeth upon examinations, they were not there. As I already stated at the beginning, the patient said they removed teeth, so the teeth that are missing is the 4-4 and the 3-5 and the 3-7 in this case.
4-4, 3-5, 3-7. Lana ke uma sibheka ke kule chart lena ke ila ebese ngichazile ngaphambilini amazinyo ke kuya ngokuthi ke izinyo mhlambi elikhishiwe elibolile mhlambi izinyo nje elavalwa ke noma ke eline feeling futhi ke abhaliwe ke lapha yana lana ke lana engathi ke kwakuwona ke set these ones were removed ne 4-4
Yeah, 4-4.
u-4-4 u-3-5 kanye futhi naye ke u-3-7 yilawo ke athola ukuthi kwakuyiwona ayekhishiwe.
So those are just the markings that we do for our own purpose to know how we're going to go about the treatment.
Lokho ukusisa nje thina ke ukusitshela nje noma kube inkomba ke ukuthi sizosebenza kanjani.
And then when we go to page 3 is where we write notes, collaborating from the examinations that we have done, the questionnaire, the intraoral examination, and also the chatting. It's more of a summary to brief anyone who's going to come, read the document if maybe the markings were not marked correctly, to briefly state those things or what's really happening there, and then we bring it up forward. If you check on the page 3, it starts by showing the date, and then the operator, which is my name is stated there, Dr. Tlokoti, and the treatment or progress notes. So in this case, it's progress notes or whatever the treatment was really happening with the patient in these terms.
Lana ke ku page 3 ama notes ke nje manje ukuhlanganisa konke ke lokhu ekwesekwenziwe ke ngaphambilini ukuchaza ukuthi imuphi umsebenzi uqala ke kumibuzo ebuziwe umsebenzi owenziwe naloyo ozobheka noma ozofunda ke futhi abesebona ukuthi yini eyenziwe.
So we are trained initially to explain how we started off the patient, which is in any patient that we treat, we need to practice infection control, which is we need to wear gloves and masks. So here I stated GM, those are the codes that we use to explain or gloves and masks were worn, and then also I wrote sterile instrument to show that the instruments that were examined the patient with, they were also sterilized, meaning they were put in an autoclave, they were fried to a certain temperature to remove any sort of bacteria that's there.
Bese kuthi ke kuchaza ke kunama code ke esiwasebenzisayo ke uGM ukuchaza ke ukuthi ke ama mask kanye nama gloves ayifakiwe ke kanye futhi ke naloko kwasetshenziswa ke noma ama instrument asetshenziswa noma ukuthi ngaphambi kokuthi asetshenziswe ke nokuthi ke futhi ke eyahlanzwa ke.
And then I stated the full mouth examination was done. The report back, it's the thing is when you do a report back, you need to also state that whatever initially the patient was asking for you to check or what you were looking for, whether it is confirmed, found, or it's not. So in this case, I was informed that I'm looking for a tooth that is either it shows that it was chipped or it shows that a gold was removed. So I wrote here that upon examination what really happened, what I found.
Lana ke bese kuthi futhi ke ngichazeke noma ngibhaleke futhi ke umlomo ke ngawubheka ke ngaqulonga ke uwonke kanye futhi ke nokubase kubhala ke futhi ne report back umbiko ke lana uchaza ke ukusho ukuthi lokho engakutshelwa yona ke i-patient uma mina ke sengiyibhekela ke ngakuthola yini lokho engakutshelwa.
So in this case, I wrote that the patient shows no sign of cosmetic fixed prosthodontic work done on them in the teeth that were present. Prosthodontic work we're referring to inlays. Inlays, we're talking about dental crowns, or we're talking about gold. Those are the cosmetic, meaning or there are things that patient obtain to have due to them looking appealing, not because they have a certain condition, unless in a crown state whereby they are forced because the tooth is broken into half. But in this case, there were no findings regarding that, meaning there was no tooth that showed that there was a gold tooth the patient ever had that came out of the mouth.
Lana ke nokuchaza ke nokusho futhi ke kungekho izimpawu ke ezishoyo ke ukuthi ke kwakunama nezinyo ke noma mhlawumbe ke izinyo legolide ake nalo noma ke elakhishwa emlonyeni wakhe.
So the other thing that I also had to do is note something that I would say maybe it's of particular concern. It's I realized the fact that the patient's teeth, the front ones, we say the front top 3 ones, which were the 2 ones were on the second quadrant and the other one was on the first quadrant. They showed sign of demineralization on examination, showing that it's a wearing off of the enamel of the tooth. It could be maybe due to lack of calcium, or it could be maybe lack of a lot of acid consumption, or deformity of the tooth, its structure not being strong enough to withstand certain acids and other things. So it's a more of what the patient consumes and what the patient's development from a child, how it has been, because some patients decide to have demineralization, they end up having demineralization due to the fact that they have maybe some maybe calcium defect whereby led into the tooth not being developed in the certain way in which they were supposed to have been.
Lana ke ngathola ukuthi ke kumazinyo amathathu ke ala angaphambili amabili ke kuhlangothi la ngasokudla elilodwa kuhlangothi la ngasokunxele ukuthi kwabonakalisa ke noma enezimpawu ke zokuthi abonakalisa ukuthi ke khona ke ukonakala okukhona ke lokho okungabangelwa ke izinto ke ezahlukile ukuthi mhlambe ke uma esekhula ke noma mhlambe ilokho umuntu akuthathayo ke manje noma ke okuyikona akufaka emlonyeni wakhe okungabangela ukuthi ke kube khona lokho yakubonakala engaqaphela ke kulamazinyo amathathu.
Can brushing cause that condition?
I would say in very, very, very rare cases, whereby also brushes, in order to cause that, the teeth have to not be strong enough for that to happen. Because even if the only thing that a brush can actually cause tearing of the tearing of the tooth, it's demineralization. It's in a case whereby there's just a systematic fact. It's not an external fact whereby a person can actually demineralize their teeth. It's something that we would say it's some sort of tooth disability we're looking at.
Angeke ke uqhubha ke noma ke ibrush kube kuyona ke engakwenza ke lokho asithi nje kungaba nje mhlambe ke asithi nje izinyo ke uma lingekho kwisimo esikahle okungabangela kona lokho kodwa hayi uqhubha.
So in conclusion, I also signed here for this part, and then these lines that we use is usually for these documents to avoid, or if there is any person who gets a hold of the document, they don't add any sort of information. So we draw lines to indicate that this space it was not filled by the examiner. Meaning, or if somebody's going to examine the patient, they need to get a whole new page of this and attach it at the back. And then that's the reason why for the markings and the cancellations underneath the notes.
Bese kuthi lana ke ila engaqeda khona ke bese kuba nama lines ke akhona ke abhaliwe lapha yana ke ukuchaza ke ukuthi uma kuukuthi mhlambe kunomunye umuntu ke ozofika afike ke naye ke afuna ukubhala lapha yana ukuthi ke cha kufanele lokho ukuthi uyothatha elinye iphepha ke engabhaliwe lutho kulona ukuthi lo ebenza umsebenzi la yena ke uqedile ingako kudala ama lines akhona lapha yana.
And then the final, the last parts of the documents includes us talking about the diagnosis. The final diagnosis from what I have diagnosed from actually viewing the patient's mouth and what is the abnormalities that's there. So in here, the diagnosis was, I wrote the patient has calculus. Calculus, it's when plaque progress from where it's being in a soft format, it goes into a hard part whereby it sits on the gum. It's the part that end up in later resulting in the gingival recession that I spoke to about there, because the bacteria now it has grown and it's getting to a certain thickness. It's starting to even feed on the free gingival, which is the gingival they were talking about. So it led to the recession that we were talking about on the other side.
Lana ngibhalileke uma sengifika ke manje emaphethelweni ke noma lokho engakutholaki ngibhaleke lana ucalculus kolokhu engichazileke ngaphambilini ukuthi bakunele inkinga ke eyatholakala ke ngokuphathelene nawo ke ama gums akhe ukuthi aye nenkinga ke ila manje esendlulela ke la ku stage son ukuthola ukuthi ibacteria manje ise iyakhuphukela iloko engikubhalile egcineni.
And Dr. I know you've already mentioned the word plaque, but can you just explain it? That
Plaque.
plaque, yes, plaque.
Yeah, no, plaque, it's in general, in normal terms, plaque, it's the development of, it's when it's long-standing, an individual has been consuming any sort of products. It could be cold drink, it could be normal food or an apple, and there is no proper oral hygiene practice, meaning the patient doesn't brush their teeth regularly, as we usually indicate, twice a day, in the morning and at night. So the food tends to remain close to the teeth, and then when they remain close to the teeth, they end up feeding the bacteria, which is found inside saliva. Saliva in general has a normal flora meaning like any other fluids that are coming out of the body. Most of them have a bacteria that's it's normal, it's standard to people, but it goes overraged when it's fed certain quantities. When I'm saying, or in giving a normal example, it's when we say we have maybe a certain patient who is explaining it in layman terms, who has diabetes, and they indicate to them, or they must stay away from salty, sugary things to make the diabetes standard, and it doesn't go overboard, and it leads to other systematic effects. So we're saying that with this patient, the normal flora, because it's fed things that it's not supposed to be fed, it grows, and then it calcifies, and then it attaches to the tooth, and it starts in a soft format. That's when we call it plaque. But if the hygiene, it's progressively, it's fair or maybe poor, it can progress to calculus. So that's what plaque is.
Lana ke esichazayo ke ukuthi asiqale ke kule la esithi khona ke ukunakekelwa ke kwamazinyo ke noma komlomo ke kungenzeki ke ngendlela ekufanele ukuthi kwenzeka ngayo. Vamise ke ukuthi ke umuntu ke akaqhubheke amazinyo kabili ngelanga noma ngosuku ke mhlawumbe ekseni futhi ke nantambama lana uthola ukuthi akwenzeki ke ngaleyo ndlela, bese kuthi futhi ke uthatha nokudla ke noma udla ukudla ke mhlawumbe lana lokho kudla bese kundlulela manje sekusondela ke noma kuyohlala ke kulona ke izinyo, bese kuba yikona ke manje lokho okubangela ka lokho esikubiza ukuthi ke iyona ke iplaque. Ubese enza ke isibonelo ngomuntu ke onoshukela la echazelwa khona ke ukuthi ukudla okuthile kufanele ungakudli ngoba ke lokho kuzoba nomthelela ke kwiempilweni yakho, yikona ke lokho okwenzekile noma engikutholile ke kuyona the patient.
And then we say the other finding is there is irreversible pulpitis. I'm going to put it maybe in layman's terms. We're just simply referring to the fact that reversible pulpitis, it's when the tooth becomes inflamed with the bacteria, which is caries. The black stuff that we see, it's bacteria that's eating away the hard surface of the tooth. So what we're saying is it ate up the upper part of the tooth. It's in the pulp, but it's at the beginning, meaning where we can clean up those black things, fill up the tooth, and that the tooth could be back to a restorative function, and it might not progress, meaning what we can actually try and stop or reverse the progression of the caries, which is the rotting of the tooth in this case. And the number of the teeth that are there that they were already marked there, already mentioned, is 2-8, which means it's the second quadrant 1-7, which is first quadrant, 3-8, which means the fourth quadrant, and then the 4-8, which means is at the fourth quadrant.
Lana ke esichazayo ke ukuthi ke lokhu bekuse kungabuyiselwa ke noma bekuse kungalungiseka ke ukuthi ke nanjengoba sibona ke ukuthi manje izinyo leli ke ibacteria leni isiyaqala ke ukulidla kodwa ke ibisingekahambi kakhulu ke isengaphezulu ke kulona izinyo so ukuthi ke bese ngathola ke ukuthi besingakwazi ke ukuthi ke sesingaklina ke manje lelo zinyo lelo bese siyaphinda futhi siyalivala ke noma ke siyalifila ukuthi ke liphinde libuyeleke noma lokho kumnyama esekubonakala lapha sikhiphe bese liyaphinda ke izinyo ke libuyela kwisimo salo abhaliwe ke lana ukuthi imaphi ke lawo mazinyo ekwatholakala ukuthi ke ayinayo inkinga wabhale ngokwama number ke kodwa lawo ma number ayachaza ukuthi yiliphi izinyo u28 u17 u38 kanye no48.
And then from there also I've already indicated what interdental spaces means, or is the spaces between teeth, the way in which the teeth are arranged inside the mouth, and I said the lower teeth have mild crowding. Mild crowding, we're talking about teeth that are not really straight, they are not really aligned. The other one is forward, the other one is at the back. So we're saying it's mild when the spacing in between it's a certain length that we usually look for, the crowding that we look for. So in this case it was mild, it was not really severe. So we just also marked those as well and say the patient has mild crowding.
Bese sishilo ke noma bese ngishilo ke ngalamazinyo ke noma uthola ukuthi kokunama space akhona ke phakathi kwamazinyo akusuka ukuthi amazinyo ke ahlangeneke nokuthi ke kunaleya mild crowding engayichaza ukuthi ke uthola ukuthi elinye izinyo ke liye ngaphambili elinye ke lihlehlele ngasemuva.
So and also the final one that we actually stated here, it's I said it's partial endot. The partial endot, the endot just stands for edentulous, meaning that edentulous is a term that we use for patients that are missing certain tooth or they're missing teeth. So here we say it's partial because certain teeth are missing, not all of the teeth. If the patient didn't have teeth at all, we'll say the patient is edentulous, meaning they don't have any teeth. So we've stated it's partial, meaning there are certain teeth that are not there, which are the ones that the patient already stated that they have removed.
Bese kwatholakala futhi ke nokuthi kwakunamazinyo ke ayengekho bese shilo ke naye ke ngaphambi noma wayeshilo ke naye ngaphambilini ukuthi ke akhona amazinyo awakhipha.
And then we go to the treatment plan. The treatment plan is the things that we are going to offer for the patient to restore them to, let's say, the mouth being at maybe it's 80% close to 90% full capacity functional. So one of the things that's there, it's we say clean scaling and polishing. Scaling and polishing just means just cleaning the teeth, removing the plaque that's there so that the gums won't be affected. That's what's happening there. And then we also have oral hygiene instructions, which is what I touched on, saying or telling the patient, no, you need to brush twice a day. You need to stop using a harder brush, get a softer brush, and also orientating them on how they're supposed to brush, and also telling them that there is maybe a certain tooth that you need to give attention to when you're cleaning. Clean there more frequently to avoid certain plaque developing there. That's what's happening.
Kanye futhi ke lana ke bese kumnikeza manje ke iplan ke yokuthi ke kufanele ke awanakekele kanjani ke amazinyo akhe ke ukwapolisha ke kanye futhi ke nama instructions ukumchazela ukuthi manje ukuxubha ke kufanele kube usekuthi uxubha kanjani kabili ngelanga kanye futhi ke uma kuukuthi ke usebenzisa ibrush elikhunike uzama ukuthi uthole manje ke ibrush ethambile nokuthi futhi uma kukhona izinyo elithize ekufanele ukuthi ugxile kulona ke noma ke ulinakekele ukudlula amanye.
So and then we say the other one it's fluoride treatment. Fluoride treatment is whereby we actually just use fluoride, which is found in most toothpaste that we use, whether it's Colgate, whether it's Aquafresh. There is a certain content inside, it's called fluoride. It strengthens the teeth. So after cleaning them, after giving the patient oral hygiene, we usually apply the gel inside a tray, and then we allow the patient to bite on it for about roughly 15 minutes to actually allow the opened gums and also the teeth that were recently cleaned for the fluoride to be actually roughly absorbed into it to protect the teeth that were actually more at risk of developing caries, to protect them from there.
Manje ke lana ikhuluma ke ngokubuyiselwa ke noma kwawo ke amazinyo kunento ebizwa ngokuthi ke ifluoride noma ke usebenzisa Aquafresh, usebenzisa iColgate ke ngaphakathi kuyona ke ine fluoride. Kunento ke engathi ke igel esithatha ke sithi ke umuntu ke akayi noma ke patient ke ayi ifake ngaphakathi noma ke ifake emlonyeni isikhathi esingangemizuzu ke ewu15 alumeke kuyona.
And then we were speaking of the restorations that needs to be done. The ones that we noted that were really severe, it was we need to replace, we need to make sure that the 17 and the 15, they're actually restored, because they were the ones that we would say the caries was moving progressively, that we need to restore in that terms. So we need to patch those teeth in a certain layman terms. And then the other thing that we also noted, it was that the patient will require orthodontic treatments to close the interdental space. It's an option of the patient if maybe they are bothered by the spaces that they have in between the teeth. If they want to close it, then we would roughly say, we recommend that they go and see an orthodontics, or they undergo an orthodontic treatment generally in any dentist that could perform, to just close the gaps. It's more of patient's appearance concern. It's nothing that's detrimental to the patient's oral function, unless if it's in a case whereby there is severe crowding, there are teeth that are misaligned, the patient can chew properly, then that's where we say orthodontic treatment is a need to arrange the teeth to its back, to its original standard familiarity that we know.
Bese kuba nalamazinyo amabili ke la engathi ke iwona ke bese ubuthola ke manje ukuthi iwona adleka kakhulu ke manje afuna futhi ke ukuthi ke anakekelwe ke wabhalwe ngokwama number ke u15 kanye futhi no17 kanye ke nale treatment kuhamba ngokuthi ke kule treatment lena ke ibizwa ngokuthi orthodontic, ukuthi ke i-patient lena ke iyamhlupha yini lento yokuthi kunamalama space akhona ke phakathi kwamazinyo. Indlela nje ke yokubukeka ke komuntu, kodwa ke uma kuukuthi ke akusiyona ke into emhluphayo ke angayike kulokho, kodwa uma kwatholakala ukuthi ke kunenkinga khona ke amazinyweni, mhlambe umuntu akakhona ukuthi ke angadla kahle, alume kahle, ahlafune kahle, noma futhi indlela amazinyo amile ngayo, ila sizosho khona ke ukuthi kunenkinga kufanele ayoyenza.
And then in conclusion, this is the treatment plan page. We allow the patient to actually sign, or say patient sign. And if you check, there is a signature for parent, for in case if the patient is a minor, and also indicates the day in which it was signed, which is the 22nd of June 2020. So in conclusion, these are the exams that we perform on any general patient that we see, whether they have any conditions, they have whatsoever. It's a standard that we do in order to find the diagnosis for the patient that we have, and also the treatment plan, and also we write it out here. So usually, as you can see, the file it ends up being stored, and then it's kept in the database. Usually we always say the files are supposed to be kept there for at least more than give and take 20 years since the patient has been examined. So they are supposed to be kept in the database. After 20 years, if the patient never returned to the institution, that's when most of the time they say that they do have the right to maybe take it and put it in somewhere in storage, but we keep them at the institution where we're operating, because we have the belief that patients are supposed to come back for their regular dental checkups once every 6 months, if they can. So this is the standard form that we use.
Yona ke form esisebenzisayo ikona lokho kwenzeka ke uma ubuka ke lapha ezansi ke ibhaliwe patient signature wase eyasign ke idate i22 zika June ngo2020 nendawo echazoyo ke ukuthi isignature yomzali uma kuukuthi ke le patient leyo ke umntwana ke osemncane ngokweminyaka ke iyagcinwa ke khona lapha ke kwi system noma ke kwindawo lena esebenzela kuyona ke iminyaka ke ewu20 uma ke kusuka ukuthi ke umuntu akatholakala noma akaphinde abuyeke kuleyo minyaka leyo ke isiyakhishwa ke igcina ke kwi storage ngoba ke okufanele ukuthi kwenzeka ukuthi ngo 6 months kufanele ukuthi umuntu abe uyabuya ke azobhekwa ukuthi ke noma abhekise isimo sokuthi emuva kokuthi elashiwe ke lapha yana ukuthi inqubekela phambili ikanjani.
Now, doctor, do you remember what time you concluded the examination, or more or less how long the examination took?
More or less the duration of dental examination. We're just talking about the examination if we're not getting into the treatment. It's a patient in standard terms. They mustn't have less than 30 minutes with a doctor or a dentist, given if what we are looking for is specific. If a patient arrives and they're saying, well, I have a rotten tooth, and then you go straight to it. When you check it, you see Urvela is rotten, you assess it, you percuss it, you realize, okay, it needs to be removed or it needs to be done root canal. That's when maybe the duration could be longer or it could be shorter in case of removing a tooth, because in most cases, if you find the source of the pain, you explain to the patient, and then that's the dental examination, not including the questionnaire. The questionnaire, it's a separate time. I would say we give it almost 15 to 20 minutes for doing the questionnaire, which is on the first page, finding out information from the patient. But when we're talking about the actual examination, when we start looking at the patient from the mouth, doing the palpation and whatsoever, it's supposed to be a standard of 30 minutes tops or more.
Lana ke uma kukhulunywa ngesikhathi ke akufanele ke kube ukuthi i-patient ke ichitha isikhathi esingaphansi kwayo ke i30 minutes kanye naye ke udokotela asikakhulumi ke ngale page esekuqaleni ke la khona abuza khona imibuzo bese eyaphendula ke yona ke ungathi ke u15 ukuya ku20 minutes. Uma ke manje sesingena ke odabeni ila khona ke ungathi ke u30 minutes. Kuya ngokuthi ke yini efanele ukuthi ke yenziwe ke nalapho la kungandlula khona ke kuleyo 30 minutes loyo.
Now, doctor, do you confirm the correctness of your report?
Yeah, in terms of the way in which the report is being done, I would say I treated it as a standard case, and then I did, given already there wasn't really much to really go on, I wouldn't say the patient has any severe dental related or any facial situations that I encountered. I would say it's kind of really standard examination, and this is how most of the patients that are close to fair to normal oral cavity examination that's been done. This is the standard that we do, so I do confirm the correctness.
Ngoba ke lana ngendlela ke esenza ngayo ke kubona ke ama patients ngako ke lokhu okuqhalathiwe noma okukhona ke la kule document ke ngiyahambisana nako ukuthi kuyilona iqiniso.
Now, doctor, you testify that you examine a person from the waist up, you examine the head, you examine the oral cavity, you inspect the face, you look for lacerations, you examine the nose, and you also examine the neck.
Yes.
Is that correct?
Ngishilo ke ukuthi ke ngambheka ke lo muntu uqala ke enzansi ukukhuphuka ke amakhala entanyeni ngambheka futhi ekhanda ngambheka ubuso ngishilo lokho ekuqaleni.
Now, allegations have been made that this patient was assaulted, was choked, was electrocuted some 3 days prior to your examination. Now, what would your comment be given your clinical examination and clinical findings?
In terms of assault, electrocution, since the patient was clothed, I'm going to conclude that when you look at a patient since he was clothed, unless if from our assessment, unless if the patient was being assessed maybe by a general practitioner or let me just say, we call them general practitioner or medical officer. That's when maybe underneath the clothes upper torso, they are allowed to take off their clothes. But from the appearance, what I could see from the patients, since the patient wasn't actually, that day I remember they were not wearing any jumpsuit overall. They were wearing their casual clothes, if I could remember. So from what I could see on the surface, not underneath the clothes, I didn't see any sign of electrocution unless if it happened underneath. As for choking, bruises on a person's neck, they can prolong, as we always say. It depends on the length and the pressure and the strength that the individual was pressing on the patient.
Lana ke kuzoba kuney'nsolo noma kuney'nsolo ezithi lo muntu lona ke washaywa, lo muntu lona ke banjwa ke ngogesi, futhi lo muntu lona futhi ke waqinywa ke. Thike mayiphendula ke lana ke ngoba wayegqokile ke ngaphandle kokuthi mhlambe wahlangana ke nodokotela ke yena ke wamcela ukuthi ke akakhipheke noma ke akhuphuleke ingubo le noma impahla lezi ayigqokile. Kodwa mina kulokho engangikubona ke akukangekho ke impawu eyishoyo ukuthi kwenzeka ke lokho. Futhi ke nokuthi umuntu aqinyweke khona la emqaleni ke kuye kuhambe ngokwesikhathi ukuthi lokho kwenzeka isikhathi esingakanani ke futhi kanye futhi ke nengcindezi eyabekwa ke noma ke ipressure eyafakwa ke lapho nkathi umuntu loyo eqinywa. Yes.
Markings of chokings, as we were taught, markings of chokings on an individual, they show in terms whereby it also relative to a patient's color. Dark people, if they are choked and they are pressed on the neck severely, it has to be at a certain severe point in order for the markings to show. But if it's a fairly light-skinned person, if you choke them or you just press their neck, there will probably be a depression if it was hard enough to lead to a patient gasping for air to a point whereby they will end up losing oxygenated blood supply to the brain. It will eventually show on the neck. And
ngekwendlela ke esafundiswa noma esatshelwa ngayo ke kuya ngokuthi ke umuntu ke uyibala elinjani ke kulapho ke ongathi ke bona ke badakhe ke uma futhi umuntu ecindezelwe ke yena ke kodwa kulabo ke abakhanyayo ke kufanele ukuthi ke bona ke isikhathi ke esingakanani umuntu ke ecindezelwe noma ke ekhanywe ngoba lokho kubona ke kuzoba khona ke okubonakalayo kuyena.
So in this case, when you look at the patient, as far as choking marks, when I was palpating the lymph nodes and checking the assessment, there were no prominent choking marks. But also given that the assessment of the patient was 3 days later, it's been proven that even in normal terms, we call them hickeys, they call them love bites. They can persist for at least over a week if a patient was actually pressed, whereby a hickey is made in terms whereby if a person maybe was in a way in which were let's say in a sort of vacuum, or they were pressed. So they can last for about a week or so if they were done properly, or also if a person was choked and there's some depression marks.
But asibheke lana ke isikhathi ke ukuthi lo muntu ufike ke noma ke patient izile ke kwisikhathi seyinsuku noma amalanga ke amathathu ke futhi ke uma kuukuthi umuntu uqenyiweke noma lo abizi ke ukuthi ke ama-hickeys noma ke ama-love bites ayahlala ke emuntwini ke isikhathi esingangeviki.
So in this case there were no certain marks that showed that maybe the patient was really choked. And as for the face, there were no lacerations or also no markings that the patient was kind of really beaten up. It looked like it's a normal individual that doesn't look like they were in any severe physical altercation, unless if maybe the altercations were done anywhere else other than the face from the neck upwards, and also other places that we couldn't see because the patient was clothed. But from my examination, what I've seen, the general appraisal of the patient didn't look like a patient was in any sort of state that they were done such things, unless if these things that were done on them trauma to to the soft tissue, especially on the body, was done in places that is underneath the clothes that I couldn't assess and see. But as far as the face go, the nose, the eyes, the way in which the neck was, and when you look at also the state of the teeth, it didn't look like this person was actually maybe severely beaten. It looks fairly normal for me.
Kulezi noma ke la engangimbona khona mina kwakungekho nje okuyinkomba noma okushoyo ke ukuthi la ubuso intamo ke lokho engikubonayo ke ukuthi lo muntu lona ke khona la ekwanguzulwana khona ke noma ke ashaywa khona ke ngaphandle kokuthi ke ungasho ke ukuthi lezi engayiboni indawo la awayegqoke khona ke noma la engangaboni khona ke kodwa kulokho mina engangikubona kwakungekho nje okuyinkomba nokushoyo ke ukuthi umuntu lona ke washayo.
Now, what was this patient posture when you were examining them? Did they show any signs of pain, any signs of discomfort?
They were coherent. They were talking. I remember since my Zulu was shaky, one of the assistants was the one who had to assist with the translation of the Zulu language, and they were speaking fluently. I think at some point the patient giggled. To me, it appeared as if it's a person who's more of worried than a person who's more of in distress of pain from the general perspective of view. And also the other thing that was also there is there couldn't be me further referring the patient to be assessed further on the body down, because from what I've seen, the patient really looked normal, and I wasn't indicated that the patient maybe probably is a trauma patient or whatsoever. I was given a fair chance by the police when they said just look for a certain thing. So when I decided to look for a certain thing, I think the patient has had a more fair chance of me not having a bias assessment of the patient, because I was looking for something and also checking other things. So meaning, or if I was persuaded and whatsoever, maybe my findings would have been maybe a bit more skeptical, but I was given a fair chance to examine the patient in a fair way.
Nganikwa ke isikhathi ke lana ke ekuyisona ke nesaneleke ukuthi ke patient lena ke ngiyibheke ke ngikulonga ke futhi ke ngendlela ke ekuyiyona ngoba ubuzo ubuthi ke ingabe mhlambe uma wawusebenza naye ke usebenza ngaye ke kwakhona yini la atshengisa khona ukuthi khona la ezwa ubhlungu khona ke uthi cha lokho ke akuzange kube khona ke nokuthi futhi ke inkinga yami kwakuwukuthi ke isiZulu sami ke singekho kahle manje ke lo owayengilekelela ke uyena ke ncedisa noma engisiza ukuthi ke angihumushela noma angitolikeleke kuyena futhi ke kube khona nala khona ke ahleka khona ke yona ke i-patient lena ke ngoba ke ngatshelwa ke uma elethwa ke ukuthi angibhekeni ilokho ke nami engakubheka ke uma kwakuwukuthi ke kwakhona ke okuwukunye mhlambe ngangizomdlulisela ke kudokotela ke okwakuyena owayezombheka kodwa ke akukho nje okwakhona noma engakuthola ukuthi uneyinhlungu ayizwayo.
Did the patient tell you that he was assaulted? Did he make any assertion that he was assaulted?
The patient didn't state any sort of situation that maybe they feel they were assaulted in anyone. They didn't. So the only thing they stated from what we have from the report, it's them admitting that they probably had a heart condition in the mining accident that they had in 2014. But in regards to that, they didn't state that.
Akashongo ke kumina ukuthi washaywa noma khona la ashaywa khona ke okuyikona nje angitshela khona ke iloku okumayelana ke nenhliziyo lena ke noma isibongo lethi senhliziyo asithola ke noma kade naso ngo2014.
And finally, Doctor, you mentioned that if something is not within your scope, you refer it to the relevant discipline, for instance, severe injuries. Was there any referral in this particular instance?
In this particular order, I remember the whole event. Immediately after seeing the patient, they asked the warden and the police, or are we done? Is the patient supposed to see someone else? And the thing is, where we work, the patient can't pass through the medical side and goes through to the dental side without the medical people referring the patient that side. Meaning, when the patient, when they got there, they got to the reception area. A file was opened. Then when they took vitals, and then when they got there, when you take vitals, the nurses that take vitals, they also end up asking the patient, or are they specifically came for the dental side? And also, I think maybe in this case, they asked the police, they came to the dental side, or they're going straight to the medical if they have any part of their body that's undental, that's not dental related, that needs to be done.
Umshushu sifuna ukwazi ukuthi ke uma ngabe usuqedile ke naye ingabe kwakhona yini la kwakufanele umdlulisele khona ke ngiyakhumbula ke ukuthi ke iphoyisa kanye nosojeleke lona ababemphelekezela ke bangibuza ukuthi siqedile yini noma khona la ekufanele siye khona umephendula ke udokotela uthi uma uza lapha yana ke kuthina ke akukho la uzovele nje uze ngo noma uzofika kumina ke ungandlulanga e-reception bona ke onesi noma abahlengikazi ke khona lapho ke bazobheka ke futhi bakubuze ke ukuthi uze kudokotela wamazinyo yini noma kukhona okuzele ongahlangena nomlomo noma amazinyo okumayela noma okuphathelene nomzimba.
So that, therefore, it means that the patient, when they came through to us, usually even if a patient, in cases where a patient has trauma cases, they first initially go through the state we're talking about. BPs are taken, they refer them to the emergency area, they check if blood pressure is stable, have they lost any blood, have they lost any fluids. When those are stable, they send them to our side, due to the fact that they notice or maybe the patient has some facial issues that are there, so we can assess them and make further referrals, meaning we'll probably have to send the patient to a maxillofacial, which is a specialist that deals with the neck, head up, in restoring it in severe trauma cases. So we, as IFIN, we are the last people that see in any healthcare situation. It doesn't matter if the patient was in an accident. If the patient was even in a car accident, they treat every single thing. They check and then they leave the part of the jaws that are broken, the teeth that are broken. Afterwards, when the patient is stable and the patient is coherent, it's fine, that's when they refer them to the dental side to have those treated, because we always say we start with the severe situation that are life-threatening. So if it was a case whereby maybe the patient, the jaw was broken and the tongue's position was shifted, it was swollen, it was going at the back of the throat, that's when maybe it will be referred to us, or we quickly need to take them to a maxillofacial so that that jaw gets rectified, so that the patient is not at life-threatening. But if it's not that case, when they come to us in treated state of certain things that they needed to have done in general of the body to us.
Thina ke sikabogcita ke khona lapha yana umuntu azofinyelela kubona ke ngaphandle kokuthi ke mhlambi isimo njena ke sibucayi kakhulu ke la khona umuntu futhi ke masithi ke ulimi ke selihlehlele ngasemuva ke kufanele azoqala kuthina ke sibe sizamdlulisela silungise noma senze isiqiniseko sokuthi lapho ke usetholile ke usizo, kodwa ke thina ke sikabogcina umuntu eza ahlangana nabo ke ngoba kufanele konke kwenziwe lapha yana ngaphambilini babheke konke, babheke i-pressure ke yegazi, bambheke nje isimo sakhe ngaphambilini kokuthi ayofika thina.
Is there the standard procedure that you've just described?
The standard procedure that we had at the medical center, and is the standard procedure that in most cases they are supposed to be followed in any trauma individual case. The thing is, they go to an emergency room when they come for whatever trauma that has happened. They get assessed there for life-threatening conditions that are there, which we're talking about, or if they are bleeding severely, if there is the blood pressure is up, whether the patient is conscious, whether the patient can talk, whether the patient has those, they get assessed there, and they make the patient stable before they could go for any other discipline, which are called the rehabilitation part. We are part of the rehabilitation part. So if a patient comes straight to us, that means already the patient has no abnormalities that they could notice there. They're just sending them for normal dental assessment that we could do. Unless if it's in a case whereby it's in private, whereby a patient comes because they got assaulted in the face and they see a tooth is sticking at the back and their jaw is not sitting well, they will say, let me go and see a dentist to fix that. That's when they in private, that's when they get to me, I will say, I can't touch this, I don't know what's really happening to you. I write a referral, I send you to a hospital.
Indlela ke ekwakwenziwa ngayo indlela ke ekufanele ukuthi nabona ke kwenziwa noma ke izinto zihamba ngayo ngaphandle kokuthi bona ke uma besemtholile bembonile ke babonile ukuthi asikho esinye isimo abamdlulisele kithina ke mina ke bese ngiyambheka ke uma ukuthi nami ngiyathola ke kukhona la ekufanele ngimdlulisele khona bese ngenza lokho.
So in other words, doctor, you're saying that a comprehensive medical assessment is performed on the patient. They take his vital signs, check for trauma, thereafter the patient is then referred to you.
Yes, that's a part of the last part of the examination, which is most cases it's rehabilitation, just as fixing what's broken regarding the patient's oral cavity or what we can't fix. Then we send to someone who's related to who's working close proximity with us.
Thina ke siyabogcina ekufanele silungiseke lokho kuyikona ekufanele sikulungisa uma kuwukuthi ke kuyinto ke esihlulayo ke yila esidlulisela khona ke.
Thank you, my lord. That will be all.
Yes. Yes, any cross-examination?
Sir, my lord.
We proceed or adjourn, my lord?
Pardon?
I was asking if are we adjourning or proceeding.
I don't know.
I only have one or two questions for the witness.
What's your time here?
25 to 1.
You want us to adjourn, sir?
No. It's only one question or two, my lord. That's unless other colleagues are.
Your colleagues, anybody wants us to adjourn?
Let's proceed.
Because he wants to prepare something or think about something?
I am fine, my lord. You can proceed. Speaking for myself, of
Okay,
course.
Mr. Ngomane?
We can proceed, my lord. Thank you.
My lord, I would ask that we take a short adjournment before we proceed with the cross-examinations.
Okay, how long?
10 minutes, man.
Are they not having lunch, this gentleman?
I think we can come back at about 2:15 and then adjourn at 1.
What's the time? Who said the time is
It's 23 minutes, my lord.
past?
23 minutes to 1.
I'm thinking about lunch. Don't they have lunch at 1 o'clock?
Yes, so we can resume at 1:45, then adjourn again at 1.
Oh, okay. We come back at 1:45.